Welcome back, everyone. Today we are going to talk about ECG, a lot of cardiac rhythms, cardiac dysrhythmia, and how to interpret ECG. Because on NCLEX, they're going to give you just a strip like that, and then you have to assess what kind of rhythm is it, what kind of treatment we should be following, what should we anticipate in that strip, what will be the treatment plan, right? So I know some of you are really, really good with ECG. Maybe you have been working on telemetry unit, cardiovascular unit. Maybe you are pro with ECG, right? And maybe some of you does not know anything about ECG at all. You feel like ECG is very difficult and very problem one. So either way, that's okay too. We are going to learn everything, whatever is needed for your NCLEX-RN exam point of view. Nothing extra. So we are only focusing on exam point of view. Okay. So one thing that I want to tell you all before we start that this class is only for like exam purpose. We have lots of other cardiac rhythms that you will see in day-to-day life. But in exam, what they are expecting you to know, we are only going to focus on that. Okay, this is not a class where you will become like fully competent work as ICU nurse. I'm just gonna give you a disclaimer because if you really want to work in ICU, of course, you need to do some more courses, more ACLS courses, BLS related courses, and then maybe that because that is one of the requirement. Whenever you get hired in the ICU or any acute settings, you need to know about these ECG. I had a lot of my students and they are already working in ICU. So they had to do these ECG courses, but in exam, we only do basics. And I know that basic is not basic. It's a lot of stuff. Okay. So, all right. So I hope that's clear. And let's start with our first slide. And before I start, I want to ask a couple of questions from everyone. That what do you know already about ECG? So these are just questions so that I can have an idea. What do you think about ECG? So that we can plan accordingly, so that I can explain in depth if needed. Okay, what does ECG actually measure? Let me know. What does it measure actually? ECG. You all can type in the chat box. CO, cardiac output. That's what you heart functioning. Okay. Heart rate. Okay. Rhythm. Heart rate. Rhythm. Okay. Cardiac rhythm. Electrical activity. Perfect. So that's what I want to see. ECG is actually going to measure that electrical activity. You put the client on cardiac monitor, but you see a lot of stuff there, heart rate, saturation, a lot of stuff. But ECG specifically, when you put those electrodes on the chest, you will see electrical conduction of the heart, how your atriums are working, how your ventricles are working. So that PQRST, how, like, what does that mean when the P wave is forming? That is your next question. What does that P wave represent? When P wave form, what is happening in the heart? P wave represent atrium contraction. Perfect. So when P wave form, atriums are contracting. And there is another way of contraction, another way of saying that atriums are contracting, that is depolarization. So depolarization and contraction is same. So if anyone asks you now, P wave represent what? Atriums are depolarizing. Okay, what does the QRS complex represent? Ventricle contraction. QRS, when QRS forms, ventricles are actually contracting. We will do electrical conduction of the heart in our next slide, but this is just the question that I want to see if you know already or no. So ventricles are contracting or ventricles are depolarizing. Okay, fourth question. Which part represent ventricle repolarization? Now we use the term repolarization. What is it? Repolarization means relaxing. QRS formed when ventricles were contracting. Now, ventricle have to relax in order to fill out that ventricles with blood. So repolarization, perfect. So that's your T wave. T wave represent ventricles are relaxing. Ventricles are repolarizing. And flat line on ECG, if you see that asystole, flat line, what will be your immediate action? Shock, CPR, what? Asystole and then CPR or shock. In the movies, you have seen a lot of stuff that, oh, patient, you see the flat line and they are giving shock. Is it okay? Epinephrine, CPR, perfect. So CPR is going to be your first choice. And besides that, because there is no electrical conduction, so we want to give epinephrine, that is your, what do we say? That is your emergency drug, which will stimulate those ventricles to contract. Epinephrine, why do we give epinephrine when patient has that flat line? To stimulate those ventricles, to stimulate so that electricity can generate in the ventricles and ventricles start pumping. Okay, so flatline asystole, and that is always your question when you get hired, and then your HR department, they always ask you this question that when you see, when do you give CPR? By the way, when do we give CPR? When you see pulseless activity, pulseless, when you see no pulse, client is unresponsive, whatever you do, client is not responding at all, so then we give CPR. But when do we give shock? When there is some sort of issue with the rhythm. Rhythm is there, electrical conduction is there, and we have to reset that abnormal rhythm to the normal one. So we have to reset that abnormal rhythm with shock. And shock is again, we use cardioversion term, we use defibrillation term. We will do that now. Okay. So let's start with our first slide. And do you know when did it start? Like, who invented ECG? That's very interesting. Who invented ECG? There are so many theories when you go online and see. So this is the guy. His name was Augustus Desire Wellers. So back in 1887, he developed this. But at that time, this thing was not understandable for a lot of people. He was a physiologist, so he invented this in 1887. So look at that, the monitors, and those monitors used to track only V1 and V2. Means V1 and V2 is your ventricular rhythm, ventricular events, what is happening in the ventricles. It didn't give us that PQRST phenomena. So 1887, because people, a lot of scientists, they used to already work that time. So they started their work like in 1600 somewhere. And in 1887, this guy was the first one who actually noted that ventricular events. But, so this is the guy. So look at that. Who was the very first person who used or developed an ECG machine? His name was Willem Einthoven. Let me write down. So Willem Einthoven. So somewhere in around 1900 somewhere, they invented this big machine, and it was very, very heavy machine. Look at that. How many people used to take care of this big machine? It was said that it usually weighed around somewhere like 270 kg. Can you believe 270 kg? It was like big machine. And if you can really see here, it's a big setup. And this guy is sitting with some solution, with some buckets here, right? Those buckets, those are, hands are in those buckets. And look at those feet. They are all already dipped in some solution that was kind of salty solution. So this Willem Einthoven was the first one who coined this PQRST. So PQRST, he was the one who actually coined that term out. And now, like after that, they did a lot of modifications. And now these days, I want to show you how it looks like these days. These are like portable ECG devices. You stay at the patient bedside, you carry your stuff, and then you put those electrodes, and that's it. It will print those paper out, and you can see that right? So now question, can RN interpret ECG? Is it under our scope? Yes, we have to, because that's a critical thing. And that's why we are getting more pay, because we have to use our brain a lot, our critical thinking a lot. And can a LPN or RPN interpret it? If they're experienced, maybe, but that's not under their scope. But can they put those electrodes and get that ECG? Yes, they can, because putting those electrodes does not require critical thinking, right? It's just putting the electrodes, and competent and experienced LPNs or RPNs, they can do it. But if it is interpretation part is always done by us, by RNs. Okay, so that's one thing. So I'm going to show you how to put these electrodes on. We use something called 12 lead ECG stuff, but these leads are not exactly 12 in number. It's just your paper who is recording 12 views on the ECG. We do not count 12 leads, right? Those are actually 10 leads. Four for the limbs, and then rest, 6 is for your chest. I'll show you how to put those. Okay, those are very easy stuff. Any questions so far? So these days, I'm going to tell you one of the incident. I was working, and one of my clients, he was in alcohol withdrawal. And when alcohol withdrawal patients are coming, they are very aggressive. Alcohol withdrawal. They will be like hyper. All the systems get like very hyper. And this client actually had a fibrillation. When we did ECG part, he was actually in atrial fibrillation. Means atriums were shivering a lot. The rhythm was irregular. So we do follow something called SIVA protocol for alcohol client here in Canada. So SIVA protocol, and then accordingly we do check the score system, and then accordingly we give the medicine. Like if this candidate is for diazepam, means Valium, or do you want to give lorazepam? If score is this much, then give lorazepam this much dose. So you have to check that SIVA protocol. But that client was like uncontrollable. He was going everywhere. He was very aggressive. And then in those kind of scenarios, what we can do? Sometimes if you're working on regular floor, for example, if it is just a medicine floor, and there we don't have enough equipment. This client was not cardiac client. Cardiac unit should be having a lot of equipments where we can record that ECG. So we, as a, if you work in medicine floor, we don't have like cardiac monitor, a lot of cardiac monitors. So for this client, what we can do when your client is going like out of control, we can initiate always CCRT protocol, right? CCRT, critical care response team. We can call them, and then they can come with this portable thing, and they'll take everything. They'll do ECG, they'll do a lot of stuff. But as a nurse, we as a RN, we have to stay there, and we should know what is going on with our patient, so that we can do some interventions right away, so that we can save our client right away. If you don't do that, your client may be gone. If you do not recognize that this is something serious, I have to call someone. You did your part, you did your assessment, and now this is the part to call the doctor, or maybe CCRT or rapid response team. Some hospitals, maybe they use different terms for CCRT or rapid response team. So call them so that they can come right away and they can save your client. Okay, so do that part. And how to interpret? Now we will see slowly. Stay there. Okay, before we start, I want you to really pay attention on this piece of paper. So ECG paper looks like this, something like light red color, right? So if you see really with detailed eye, so look at that. Like we have like bold lines. We have like very large boxes here. And every big box, where a big box is having small boxes. And how many of them we have? So it's a big, large box. And that large box is having what? How many small boxes? Total 5. Okay. So we have total 5 small boxes. Why we are doing this? Because this is going to help you to understand further. This is very basic. Okay. So stay with me. So, and just know that don't worry about this millivolt or millimeter. Don't worry about that. Just focus on time, the second. So one small box contributes 0.05. And how many do we have? 1, 2, 3, 4, 5. So just multiply 5 multiplied by 0.04. How much do we get? Somewhere about 0.2. I cannot say 0.20. Actually, it is 0.20. But here, what is the rule? We do not use that. We call it trailing zero. Trailing zero. We do not use trailing zero. Right? So it could be 0.20 second, but I would say 0.2 second. So one large box contributes 0.2 second. 0.2 second, not even 1 second. It's a very small fraction of 1 second, 0.2 second. Right? So then we know we will use this later on because we do have this P to R interval time. We do have QRS complex, and that time we do need to know about QT interval. What is that ST segment? So we'll do that, those numbers. Those are very important and those are standard. I want you to pay attention on that because that's a part you have to memorize those numbers. There is no way that there is some basic to understand that. So that's a part where we have to pay attention because those are the things that we need to memorize those things. So let's go to this area. So if you really see here, we have PQRST, as we already said, P forms when atriums are depolarizing, QRS. And if you pay attention here, Q, when Q is forming, there is slight dip down, slightly down. I'll tell you later on why we do see that slight dip down. So QRS is forming, that time ventricles are depolarizing. Okay, depolarizing means ventricles are contracting, and T form when ventricles are relaxing, means repolarizing. Okay, very important. So now this is electrical conduction. So let's connect those things with this part. So before I start, we already know that how does that cardiopulmonary circulation work? Everyone knows that blood comes from where? From the veins, from the big veins. Which are those? That is your superior vena cava, inferior vena cava, and everything. Superior vena cava and inferior vena cava, everything is draining their venous blood back to the right atrium. And from right atrium, it is going down when right atriums are contracting, going down to the right ventricle via which valve? Tricuspid valve. And from now, blood is in right ventricle, ventricles are squeezing, contracting, and pushing that or forcing that blood to go into the lungs via that pulmonary artery. But we do have a semilunar valve there. Which one is it? That is pulmonic valve, right? So now all the blood is in the lungs, and then this point, this area is like this area. Lungs are the one who are converting that deoxygenated blood into oxygenated blood, making that blood again fresh, which can be used by our organs. So now lungs did that part, and now that fresh blood is going via pulmonary veins. Pulmonary veins, we have two veins from each lungs, and they are going back into the left side of the heart, left atriums. And from left atrium, it is going down when the atriums are contracting. It is going down to the left ventricle via which valve? We have mitral valve or bicuspid valve. So from there, it is going into the aorta. So look at that, how that structure is. So when left ventricle is having blood, so now it is going against the gravity because it is going, it has to go upward, right? Upward to the aorta. So ventricles have to be very strong enough so that they can push or force that blood to go or to move forward against that gravity. And on the top of that, we do have aortic arc. So left ventricle should be the strongest one out of all those four chambers. They have to really work hard. So that's a thing, like now we can use our common sense that why left ventricle is slightly bigger in size as compared to all the other three chambers. We already know because left ventricle is the strongest one. They have to pump against the gravity, against the systemic vascular resistance. so that blood can move forward, right? So we do have a valve in between left ventricle and aorta, that is aortic valve, which is again your semilunar valve. So we discussed like that was normal physiology. So now here is the question. Heart is doing the part, heart is pumping, but who is telling the heart to pump? Who is telling the heart? Who is the one who's telling the heart to pump now, to contract and relax, contract and relax? Who's the one? That is your electrical impulses, which are going from SA node, AV node. That is where, and look at that. This is so interesting. So heart generate its own electrical impulses. And those structures who are responsible to generate those electrical impulses are your SA node, your AV node, your Purkinje fibers, right? So what do you think that when, like how early we can see electrical impulses in someone? How early? When baby is inside, when baby is fetus, and how early we can detect that heartbeats? Usually it say that babies start fibrillating their heart around anywhere about fifth week. Look at that, fifth week. And then that heart rate can be detected anywhere around 6 to 7 weeks. So we can say between 5 to 7 weeks, we can see our heart is working unstoppable from that time when we were inside the womb. So our heart was working, and from that time, we don't know which energy is giving those supply. People believe that our SA node, AV node, they have some special cells who generate that electricity. But think about it, how we all are operating. There is some energy inside us. Who's creating that electricity in the heart? God knows, right? So that is very interesting part. And since then, it is working unstoppable, and it will end when we will die. So see how much heart has to work. Even though we are sleeping, heart is working, right? Even though we are not doing anything, we are resting, heart is working. Heart is pumping. Unstoppable, unconditional, right? We have to protect our heart. Heart is everything. If we don't have heart, we cannot have anything. Right? So the SA node, let's go back on concept. SA node. So when SA node is stimulating, so we have SA node here. So SA node, when SA node is firing electricity, it is generating those impulses. So remember the golden rule, when SA node or anywhere, wherever pulse is generating, that part will contract. Okay, so now when SA node is contracting, where is the SA node? In the right atrium, in the atrium. That does not mean that it is on the right side of the heart. So atriums, it has to work both. So both the atriums will contract when SA node is firing. So when SA node is firing, atriums are contracting, and now on ECG, what we can see? P wave. On ECG, we will see P wave. Both atriums are contracting and like together. They are syncing together. Otherwise, if one is working, other one is not working, there should be some chaos. So in order to work properly, they have to work together. So wherever that impulse is, that part will contract. That part will contract. They will not relax. They will contract. Okay. So after atrial contraction, the impulse moves little down. Where? Now to the AV node. If we can see, both atriums are sending signal to the AV node. And where that AV node is sitting? AV node is sitting where? Atrioventricular septum. In between that septum, atrial and ventricle. So now, when impulse is going there, we call them something called like one-way people, right? They're gatekeeper. They are the one who are pushing against, like who are pushing the ventricles to work against the gravity. So if we don't have AV node, the impulse will not come down. So they are working as a catalyst, I would say. They're sitting at the septum area. They're working as a catalyst. So from there, the pulse will go down into the bundle of His and then Purkinje fibers. And if you see here, this impulse is stopping right there, right? Stopping right there. So if we go back again and see this septal area, AV node is controlling impulse flow. If it is not there, it will be chaos. It will prevent that chaos, and it ensure that that ventricle should contract on time. If there is any delay or if there is any issue with AV node, ventricle will not contract. And from atriums and ventricles, we are worried about ventricles more because they are super important as compared to atriums. Everything is important, but ventricles are more important because both sides of the ventricles, they have to work against the gravity. From right side of the ventricle is working against gravity because it has to push the pump, force the ventricle to push the blood against the gravity so that it can go upward in the pulmonary artery. So this way they are going up. From there, it is going everywhere. And from ventricle, left ventricle, it is going into the aortic arc, right? So, okay, from this part, from up to here, the impulse will travel further down to stimulate ventricles. So now, if you really see here, where we have his bundle or bundle of his, some people call it bundle of his bundle. Anyway, it is both ways, okay. Now, where is it? If you really see here. So AV node, and right after that, we have a bundle of his. So AV node is going to receive the impulse from the SA node, and here we have bundle of his, and it will go from bundle of his to downwards. So atriums are already have contracted. And remember what we said, whenever the pulse is there, that part is going to contract. And that is what we know. So right now, the impulse is here in the AV node in the bundle of his. So what is going to contract at this point? Bundle of his area. Bundle of his area, that means that septum area. Septum area, that is the starting initial part of the contraction of our ventricles. So that time when it is in the bundle of his, now that little, what we say, little deflection in the Q wave, so that time it is happening. So Q wave is forming because now ventricles have started working their work. They're working, they're contracting. So now the septum is contracting up to this area. From septum, what is happening now? Impulse will go down. And we have two branches. One is right bundle branch and one is left bundle branch. So look at that, right bundle branch, left bundle branch, and we have Purkinje fibers. These are your fibers. So up to here, it will stop here. So when it is going down at this point, I would say P wave was forming when atriums were contracting. When it was coming at septum area, that point Q was forming. And now this is the R wave. So when the impulse travel through those bundle branches, and look at that, how much area it has to cover. A lot of area. So that time your R wave is forming, which is major one, right? Q, slight deflection, and then positive inflation in that rhythm. So that time our R wave is forming when pulse is traveling down. And what is happening when pulse is there, electricity is there, that part is contracting. So when impulse is coming here, that time R is forming. R is forming. It's a big pathway they have to travel, right? And that's it. So R is forming. And what about S? When S is forming? S is forming when? Any idea? So now, listen to me. So R wave is forming up to here. So when wave goes up to this area, and after that, do you see any electrical conduction here? No, right? At this point. So it disappears at this point. And of course, this is a final touch, final, I would say, push that ventricles have to do. So when your S is forming, that means that ventricles are at the maximum, ventricles are maximum contracting at this point. So now we can make a relation. So P was forming when SA node was firing. We were having P wave, and then we have slight deflation, and that's when your AV node was active, AV node was firing. So that time we had Q wave, and then this had to go down and had to cover a lot of area. So now this is the time when R wave is forming. And QRS, S is the final push. So at this point, ventricles have to be really, really strong in order to contract properly so that they can push that blood against the gravity, right? So here we have S wave. And then after S wave, do you see anything? Now, this is the time when ventricles are relaxing. So after S, you will see T wave. T wave means ventricles are relaxing. So now you must be wondering, atriums were contracting, ventricles were contracting, ventricles were relaxing, T wave is forming. But around what time our atriums are relaxing? And what time? Because as I said, atrium, they have to relax in order to fill that blood, right? When they're relaxing, blood is filling in the atriums, and then they have to contract so that blood can go down. So they're contracting and they are relaxing. But we cannot really calculate that there is no any wave which calculate the atrial relaxation time, right? Because there is no way. Our ventricles are super, super important. That's why we have Q, R, S, and then T wave. But at the back side, when ventricles are actually contracting, at that point of time, maybe our atriums are relaxing, but we cannot denote those things all together on an ECG paper. Makes sense, right? So we are more worried about our ventricles, how they're working. If there is any dysrhythmia, specifically in ventricles, that is chaos. That is something which is very life-threatening. Any question? So now we can actually see that in ECG tracing, if you go back, so PQRST, now we can relate when P is forming, when QRS is forming. Tanya, is ventricular depolarization and atrium repolarization occur at the same time? Yes, that's correct. But we cannot denote atrium repolarization on the piece of paper because ventricles are super important. We want to see their ventricular activity. So back in the game, at that time, when ventricles are contracting, atriums are relaxing. We cannot see on the ECG paper. That's the thing. All right. Question so far. So that was basic, very basic. We all have done, I think, in first year of your nursing. Who thinks that it was tough when we're in the first year? I still remember we used to do something called cardiac cycle. Remember? Cardiac cycle, cardiac output, how to calculate a cardiac output, what was the formula, right? So those times were very interesting. I miss my college, by the way. Okay, so now everything is super, super clear. As a note now, how does that, if we have to wrap up, so now how does that electrical conduction go? The SA node fires, it also gives the impulse to the left atrium and right atrium. They are both contracting together and that is forming your P wave. Then it comes down to the AV node. If I have to explain again, somebody is asking, please explain again. So then it comes down to the AV node and the bundle of His. So that is the septum. So that's where we get small Q wave. And then it goes this big area in the ventricles. So now we will see R wave. And the last part of the ventricle where the final pushes their final, I would say, ventricle have to be strong enough, powered enough so that they can squeeze. So that time we have S wave, which is forming. So QRS is equal to ventricular contraction. The ventricle relaxed and then we get the T wave. So that's the basic pattern of your ECG. All right. So now, ST segment is very important. When you see this ST segment, this area is very important. ST, why it is very important for your exam point of view. Why? Think about what is going on when ST segment is forming, and you will be seeing that there is nothing. It's just a plain flat line. We call it isoelectric line. Isoelectric. This is plain line. Nothing is happening. Heart is filling. Okay. So what is happening when ventricle were having that S wave? Ventricle was relaxing. That was the final push, the final contraction, the maximum workload on the ventricle. That is S, right? So if it is right ventricle, it is pushing. Think about that right ventricle is pushing the blood against the gravity to the pulmonary artery, and the left ventricle is pushing blood against the gravity to the aorta. So that time we have S wave which is forming. So that moment, once it is done, and then the pulse was disappearing at this point, pulse was disappearing. So that time from the beginning of once like ventricles are contracted and now it is gone. So maximum workload of the heart, it is gone. So that moment, it is called the time when ventricles start relaxing. So it's the beginning of the relaxation. So from S to T segment, that is called relaxation time. And it is very important for us because once it gets to T wave, the ventricle is already relaxing up to this time. So the final pushing time when the ventricles are under peak contraction is when they are under maximum stress. Okay, but because the right ventricle is pushing and left ventricle is pushing, and the maximum stress time over the ventricle we have. So if something goes wrong in the ventricle, which is not okay, there could be maybe you have heard about ST segment elevated MI or non-S ST segment MI, right? So this area could be elevated, could be depressed. There is some issue. So if you don't see this isoelectric line, if they say ST depressed or ST segment is elevated, that time there is something bad happening in our ventricles. Okay. So when you see ST segment elevated, what is happening in our myocardial layer? Our heart is not getting enough oxygen, right? Enough oxygen. There is ischemia or infarction, I would say. That time ST is elevated. Elevated. So means ventricles have some trouble. Doesn't matter if it is elevated or deflated down. So they have some trouble in it, right? So you will see if you don't see isometric line, there is some trouble. We have to figure out what is going on. So ventricles are messed up. We will see that. Okay. So now let's talk about something else. But before that, any problem with ST segment problems? Either way, it's not okay. Maybe there is ischemia, myocardial ischemia, or infarction. That's why we see infarction. So in which cases, what do you think? Like in which cases we see ST segment elevation? ST segment is elevated always when there is full thickness damage in the heart. Full thickness damage happens when? It happens when, for example, I know I gave you one condition, which is MI. What else? Full thickness means heart layers, which is your, what are the three layers? Your endocardium, pericardium, and myocardium. So all these three layers, full thickness, they are damaged. Maybe there is infection, maybe there is some issue going on. So full thickness damage means think about your pericarditis, means all these layers are involved. You will see elevation, right? There is another type of angina. Those who have like our student, they know already. So there are three types of angina, right? Stable, unstable, and Prince metal, which is your vasospastic one. So in vasospastic one, which is Prince metal, you will see always ST segment will be elevated because spasms are there. They are causing some major damage. That's why that Prince metal variant angina, vasospastic angina is the dangerous one, right? And your unstable is also dangerous one. So you will see ST segment elevation in those areas. And if you have to talk about ST segment depression, in which cases do we see depression? in non-STEMI. So STEMI is urgent. If you really have to compare between a STEMI and non-STEMI, this requires urgent care, but it is not deadly as compared to STEMI. In STEMI, we already know that permanent or full thickness damage has been happened, but in non-STEMI, maybe it's like less severe, I would say. It's not full thickness, it's just on the inner layer, which is causing trouble, inner layer, right? But again, we need care. But if you really have to differentiate between STEMI and non-STEMI, STEMI is the one which is a dangerous one. That is happening because full thickness issue is there, right? And other thing, hypokalemia, yes, you are right. ST segment is elevated in hyperkalemia, and hypokalemia, there are other conditions. Digoxin effect, okay. All right, so that's pretty much. Okay. So let's see this video quickly, which is 3D video, so that you can have better understanding.
The conduction system consists of the following components. The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium, near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires. Electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals traveled from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
Perfect. So, okay. So I hope now you might be having some good idea about all those terms that we use: depolarization, repolarization, And then when are those waves are forming, right? So let's go further. I'm not going, already we have done a lot. So here is another way. This is the best picture I can bring for you. So atrial depolarization means atriums are contracting. Look at that. And then P wave is forming. QRS is forming. QRS complex is forming when ventricles are depolarizing. T wave, and usually sometimes there is U wave too, which does not have any significance. Usually we don't see a lot on ECG papers. Okay, but these numbers are very important to know. P wave, when that P wave is forming, what is happening? Atrial depolarization, Q, ventricular depolarization, R wave, it's just major ventricular depolarization, bulk of ventricles or major of the ventricles are involved. S wave, that is your terminal phase of ventricular depolarization. T wave is your when ventricles are repolarizing. PR interval. So we did ST segment. So PR interval is conduction time from SA node to AV node. PR interval is conduction time from SA to AV. We will do what is that time frame. Okay. And just know that these are our natural pacemakers. If it is your SA node fires at 60 to 100 beats per minute. So that's just the normal activity of your SA node. But think about if SA node goes out of control and if it starts firing a lot, then that will be dysrhythmia. If it does not do its work at all, that means again, SA node is not there. Maybe we need to think about pacemakers. Okay, AV node is doing its job. So think about if SA node fails, then AV nodes are the one who takes over. But they only beat 40 to 60 beats per minute. They will serve the purpose, but they're just called backup pacemaker, secondary pacemaker. Primary is your SA node. We need SA node. If SA node fails, then AV node will take over. Think about if AV node is not working, then maybe your ventricular pacemaker, which are your Purkinje fibers, they will take over. Okay, and they beat only at 15 to 40, very less. Still, they will give us some sort of cardiac output by contracting, but not a lot. Maybe that will be not sufficient for our vital organs. So in order to work properly, all these electrical conductions should work efficiently. If there is any issue, maybe there could be some sort of heart block, right? We need to think about pacemakers. So we will do AV blocks, but maybe I think maybe not in this lecture, maybe in the next lecture. Okay. So P, we have done that. QRS, ventricles are contracting, that is just general. So now by this time, I want you to think again. Take a break, think again what we have learned so far. Was it easy and making sense? Or is it too tough going from the head? It's not coming in your brain, it's going out of control. Not hard, it's easy, right? Very easy. When you use your concept, these are very basic things. Everyone should know that. So now let's talk about how to place those ECG leads. Look at that, they're 10 in numbers, but we just use 12 lead ECG. Why 12 lead? Someone said it's too hard, but you have to do it. If you are a nursing student and if you have done your 3 years, 4 years in the nursing, and then if you're working already, it should be easy, right? These are basic. We start learning from our first year. Okay. But sometimes, again, I am not judging anyone. Sometimes our IQ level is not same. We have 100 students at this time. So everyone is having different understanding level. Maybe someone grasps the thing fast. Someone, maybe they need some time. They need to listen to this lecture again and again. And then it will make sense for them. But that's okay. If you think you are that person, you're a slow learner, maybe you need to pause it here. We will post this video on our YouTube channel so that you can watch this again and again if you have any issue. Because I believe that this is it. This is what you need to know about all those ECGs which can appear on your NCLEX-RN exam. Other than that, you don't need anything. And I'm 100% sure about that. Okay. All right. So let's talk about ECG. How do we place them? Okay, so we say it's 12 lead again. It's not 12, it's 10 actually. So why we say 12 lead? Because it just gives us 12 views. So we have 4 for our limbs. If you can see here, right? So arm, left arm, right leg, left leg. Okay, so those are for the limbs. Maybe in India, the one that we used there, so we used to have some clips here. We used to put those clips on the limbs, 4 limbs. But here, like those are pre-made. They have some gel or some sticky thing underneath it. So we can place it somewhere. Maybe if it is on the upper arm, maybe it can stay up somewhere between shoulder and elbow, or maybe somewhere on the upper chest. So the way they are placing here, so it's your limbs. It's not getting any electrical impulse like from the heart. So it's the limbs. And for the legs, we have right leg and left leg. So we can place in the lower abdomen or anywhere on the leg. So, but one thing you need to make sure that we are exposing our client. So privacy is going to be very important. We are exposing, so make sure that you give enough privacy to the client so that they can sit comfortably. They shouldn't be getting panicked. Let's say if it is a female, they should be, sometimes they're uncomfortable. So make sure you give them comfort. That's very important part of nursing. Do not judge, do not do anything, give them comfort. If possible, close the curtains off and then do your part, okay? So 4 limbs, and now these leads are super important. So we have 2. So from here, we can actually see the anatomy. So here is the rule. So when you see those electrodes, it should be written there, this is V2, or there should be some color coding. Some facilities, they use colors, different colors. And from those colors, who are very pro, who work in ER or ICU, they know already that this is yellow color and it should be there, it should be here, okay? So if you're not pro with that, just know that read which is your V2. So if I have to pick one and I have to put that electrode, first electrode should be, which one? Which one will you pick? Is it V1 or V2? Or V3, V4, V5, V6? Which one? So I always encourage you to pick V2. So now, if you can see V2, sometimes, by the way, you can get question if you are here for your REX-PN exam, NCLEX-PN exam, because a practical nurse should know how to put those leads on. So you should know. Sometimes they'll just give you the picture and then you have to localize that where we can put V2. So if you can see here, V2, it's where? It's somewhere in between these ribs. So in between these ribs, we call always intercostal space. Intercostal space. So which intercostal space do you think we are putting that into? So don't think about this clavicle. This is your first rib. This is second. This is third. This is fourth. This is fifth. No. Okay. Yeah. So in between 1 to 2 ribs, here is your first intercostal space. 2nd and 3, second intercostal space. 3 and 4th, third intercostal space. And then we have 4 and 5. Between 4 and 5, we have 4th intercostal space. Now, can you really tell me in which intercostal space we are putting that V2? 4th or 3rd? This is 4th. V2, this is 4th, between 4th and 5th. So that is 4th intercostal space, right? And this is your sternum, and that is on the left side. Always know this is right side of the patient, this is left side of the patient. When patient is facing yourself towards you like this, so my right side is this and left side is this. So this is on the left side of the sternal border, and that is where your tricuspid area is. If you remember that A bit N. So that is where your tricuspid area is. So V2 always place first. Where we do put that? At 4th intercostal space. And what that 4th intercostal space called, that is your tricuspid area. Tricuspid. Okay? Tricuspid valve. Tricuspid. Okay. So heart is sitting like something like very oblique side. Tilted on the right side, but majority of the part is on the left side. So now, after putting V2, now think about your V1. Okay, now we know exactly where do we need to put. So you have V2, and right on the, like at the same level, on the right side, you have to put V1. Very easy. V2, and we know the location. We put the V2, and then at the same level, on the right side, right sternal border, put V1. All right, we're good? And after that, which one do you want to pick? So far, we have done V4, V2, and then V1. Now, think about your V4. V4. Next will be not V3. I'll go with V4. Always go with this sequence. That will make more sense. Okay. V4. So where do we put V4? So that should be on your, look at there. So V4, which is right here. We're not thinking about V3, right? It's V4. So if it is your fifth intercostal space, this is sixth. So in which area, which intercostal space do you think it is? V4. So this is your fourth intercostal space. V4 is your going to be fifth intercostal space, right? Perfect. You guys are pro now. Fifth, not sixth, right? Fifth, if you can really see. So always know how to check that. So first one is your, like, if you really palpate this area, you see, you feel your like clavicle bone. It's your clavicle. That's not your rib. But right besides that, if you really press that area, you will see. Okay, you will see that the first rib. So first and second, if you really press that area, if you're not obese enough, you can feel that, and then you will figure out that is your first intercostal space. This is just your like you should know about it. This is just basic how do we check that those anatomical landmarks. So fifth intercostal space, but V4 should be in your fifth intercostal space. So this should be your third lead. And fifth intercostal space. What do we have in fifth intercostal space? That is your mitral valve, which is your bicuspid valve. So here we have mitral, or some people call it mitral, bicuspid, anything is okay. Okay, so V4. Now we have placed V2, we have placed V4. So in between, I don't worry too much, wherever you feel like the center point. So then you can put that V3. So if you can see, it is coming right on the ribs, but that's okay. But you need to see, like, it is not going like straight, right? It is following that ribs pattern, how those ribs are. Ribs are like kindly like this way, right? When you feel those ribs are kind of not straight, it's kind of giving this shape. So you really have to figure out, you cannot put those on ribs. It should be in between that, but follow that the pattern, this slant area. I would say not straight, not flat, should be like this. If you see this guy here, so it's not straight, it's coming like and following that rib line, right? Intercostal space. So that is done. V4, V3. So we are done with V1, 2, 3, 4. Now think about your V6 first. Okay, V6. And then we will see V5. So V6, where do we put V6? Someone's here already photo in the chat box. So V6 is in the mid-axillary line, but which space is it? It's still in the fifth intercostal space. V6, fifth intercostal space, but it is mid-axillary. So if you see mid-axillary, it should be somewhere here. So that is again at fifth intercostal space. And how about mitral valve? It should be mid-clavicular line. So clavicles are here. So if you see the midpoint and draw that imaginary line, and you'll see V4. Okay, so that should be mid-clavicular, V6 mid-axillary. And excuse my spelling, okay? As long as those are making sense, that's okay. So then we are done with V6 and put that V5 in between V4 and V6. But follow that same pattern. Do not go like flat. Shouldn't be on the ribs, because if you put on the ribs, we cannot see what is going on in the like heart. It should be in between the ribs, in between the intercostal space. Okay, so this is the order. So again, let's do the recap. V2 first, that is on fourth intercostal space, where you have tricuspid area, which is on left side, left sternal border. After you place that V2 here, this is first one, then go exactly and follow the same fashion, same level on the right side. So that is your second area. And first is done, second is done. Now think about your V4. V4 is if you draw that mid-clavicular line, and that's on fifth intercostal space. So put that V4, that is your third lead. And then between V2 and V3, put that V3, that is your fourth placement. And after that, think about V6, that should be in your mid-axillary line. Again, we are sitting in the fifth intercostal space, not in the fifth intercostal space, because that way you're surrounding your heart with those electrodes, and those electrodes will see what is going on. They have the sensors. They will see what kind of electrical conduction is going on in the heart, right? So V6, we put that V6, and then in between V4 and V6, then at the end, we will put V5. Okay, good. So that's how it works. And majority of the time, you don't have to memorize that. Where do we need to put? If you know just V2, V4, and V6 placement, you will get other placements done. Right? Easy? Okay. If it is easy, let's go further. So these are very important events. So if patients are obese, you need to use the common logic where it should be. If they're obese, you cannot see, but you have the idea. And here we have the heart around this area. So that's why we should be pro in that. Okay. Okay, so these are the major events that is happening. P wave. Look at that time frame. Time frame. So one of them, I'm too much concerned about the PR interval, and then we have QT interval. Okay, so those are very important intervals, very important timings. But other than that, P wave. When P wave is forming, think about the first paper that I showed you. So it should be less than 0.12 second. That means if you think about a large box, and that large box was having 5 small boxes, 1, 2, 3, 4, and 5. 1, 2, 3, 4, 5. So one box was containing how much time? 0.04 second. So it should be like less than 3 boxes. P wave, when P wave is forming, it should take only 3 boxes or less than that. Should be less than, right? Shouldn't be more. Less than 3 boxes, small boxes. 3 small boxes. Okay, less than or maybe equal to. So what is happening when P wave is forming? We all know. I'm bored now. But if you do not find, you cannot locate where that P wave is. So P wave, if you cannot locate that P wave, instead of P wave, it's just like waves, then just know that this is atrial fibrillation. Okay, that is very important. If you cannot locate that P wave, it's waving. So that's the fibrillation. And AFib is always irregular. Then we have PR interval, PR, the time from SA node to AV node. Okay. So that time should be between 0.12 to 0.2. We have already done PR interval. So that maybe takes one whole large box, right? 0.20. So 5 boxes contain 0.20 second. So 3 to 5 small boxes, or maybe one large box. PR interval. If it is too much, PR interval is too much, that means there could be the tendency of having heart block. If it is too less, that is WPW. Now, what is WPW? Anyone? That is called Wolf, Parkinson, White. Those were 3 people who first invented this type of arrhythmia. We call it Wolf, Parkinson, White. It looks like same like SVT, abnormally very high rate in the ventricles. Interval, very high rate in the ventricular tachycardia. It's look like SVT, but it's not. But it can cause SVT, very high rate, WPW. Okay, this is called pre-excitation syndrome. Some people call it that there should be some extra electrical activity going on. So before SA node, it has to go to AV node and ventricles. But in WPW, they bypass SA node, and there is abnormal circuit which is coming and going, coming and going in maybe one side of the heart, or maybe on the other side. I'll show you later on. Okay, so if PR interval is very less, think about if it is very less, 0.2, not even 3 small boxes, we can have WPW, ventricular tachycardia. If it is too much, means heart block is there. QRS complex should be always this much. I want you to pay attention to these numbers. Okay, these are very important numbers. These are standard. This is where you need to memorize these words, or I would say timing. So 0.06 to 0.10 second. So that means they're not even making, thank you so much for sharing that photo. So 0.06 to 0.10 second means 3 to 5 small boxes, and not more than that. It could be like maybe less than 3 boxes. 0.12, that means 0.04 is small 1 box, and then it could be like maybe less than 3 boxes, 3 small boxes. So that is the normal QRS complex. If it is too wide can cause triple B is what? Bundle branch block. Bundle branch may be right or left bundle branch, but there will be, like, if it is QRS is wide, that means that, think about QRS forming when ventricles were contracting. So ventricles are taking too much time to contract, and they don't have enough time to relax. If they do not relax, blood will not fill up. We don't see the cardiac output, right? So wide BBB, like ventricles are like squishing. So maybe there could be ventricular arrhythmia too. Ventricular arrhythmia means that pulse is generating, but rhythm is kind of, think about your ventricles, that it is not following SA to AV pattern. Ventricles are the one who are generating its own rhythm. That rhythm is not coming from SA node. They're generating, like, ventricles are generating their own rhythm. And ventricular rhythm, like, they think about your V wave. Think about ventricles are generating their own rhythm. Think about your VTach, ventricular tachycardia. So those can happen when there is some issue with QRS. When you see QRS complex is wide or something is there, you can only see QRS. There is no P wave, and they are very wide. It could be bundle branch block, or it's just ventricles are like in tachycardia, or maybe they are fibrillating. So they're taking too much time. They're not resting at all. And then ST segment, as I said, that is ST segment when that flat line is there. So this is called early ventricular relaxation or repolarization. If that area is elevated, STEMI. If that is down, maybe think about your other types of angina. Ischemia is there. One side is infarction, one side is ischemia. They're different, right? So if it is down, ischemia. T wave, it should be less than or equal to 0.16. That means small boxes should be like 4 or maybe less. So T wave is forming when ventricles are repolarizing, means relaxing. So this is standard. They're taking this much time to relax so that they can fill. And if T wave is peaked, think about hyperkalemia. If it is down, think about hypokalemia. QT interval is 0.36. So Q, what is happening from Q to T? So Q, R, S, and T. Ventricles started depolarization and then repolarization. So that is total time taken by the ventricles in contracting and relaxing, right? So that is total time, ventricular activity. This is the standard. If it is too less or too high, maybe there is some sort of dysrhythmia. So if it is too high, when QT interval is prolonged, think about one deadly rhythm, which is your torsades. Torsades, by the way, it's a French name. That's a funny name. Some people call it torsades d'Apua. That's how it should be pronounced because it's a French name. So lots of twisting is there. Okay. And then last one is your R to R interval. R to R, R to R. Right? So that is time between the one beat. So when one R is forming means ventricles pushed. So we got one beat. Another R is forming means one more time ventricles pushed or squeezed. We are getting another R. So that means it's just that R to R means time between in each beat when you see. So if it is too fast, means problem. Okay. All right. So those are important values that only the thing that you need to memorize. Okay. So maybe take a picture of it and then memorize it. So now let's go to the basics. So this is, by the way, WPW, Wolff-Parkinson-White syndrome. Someone shared the photo already. Look at that. So in WPW, the normal should be like here. So SA node is firing, both atriums are contracting, and then impulse is going this way from here. It is going this way, and then it is going down. Right? So that is the normal sinus rhythm. It should be like this way. But in WPW, SA node is bypassed. Okay, so there is a normal circuit, and that is coming back and forth, back and forth. That AB node is firing, and ventricles are depolarizing like very fast. And then again, it is not going to SA node. SA node is bypassed. So it should be done like that S segment, the Purkinje fiber should do their maximum workload, and it should like maybe eliminate somewhere here, right? Somewhere here, but it is going back. So ventricles, they are giving their own electricity, and ventricles are having some abnormal circuit. So instead of SA node, who should be generating that pulse, now it's your ventricles. Some rhythm is originating, or maybe electrical impulses are originating from ventricles itself, and they bypass SA node. So that's abnormal electrical pathway or abnormal circuit. So these are the three people who discovered it. That's why we always remember them. Okay, so they cause very fast heartbeat, kind of tachycardia, can cause SVT. SVT is also supraventricular tachycardia, very fast rhythm. That is most likely regular one. We will do SVT too. So let's talk about normal sinus rhythm. So that's the first one. So now, when we start normal sinus rhythm, if you can, why we call it sinus, first of all, why we call any rhythm sinus? Because it does have all these components, P, Q, R, S, T. If anything is missing, if you cannot locate P wave or maybe T wave or QRS is some abnormal one, that is not your sinus rhythm. When you see PQRST, that is sinus. And one more thing, two things you have to follow before you tell that this is sinus rhythm. Second thing is, ask yourself whether the impulse is regular or irregular. If it is regular, and if you see PQRST, this is sinus rhythm. I'm just saying sinus rhythm. I'm not saying it's normal, right? Because we have sinus bradycardia and sinus tachycardia. Those are normal one where we see PQRST, but one rhythm is very low, one rhythm is really fast. That is normal, not normal, right? So normally, if it is meeting this criteria, we call it regular rhythm. So let's see if we can figure out where we have PQRST. Can you look at P wave? There's one. There's another one. P wave, P wave, P wave. So before any QRS, we have P wave, right? And then we have QRS. We have QRS, QRS. After every P wave, we have QRS. It's not like that P wave is coming and then we don't see QRS. That's sometimes called sinus block or some sort of heart block. Okay. So every time P is coming and right after that QRS is forming and then we have T wave. So we can see all these things, PQRST, 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 and how many times we see that? 1, 2, 3, 4, 5, 6. Okay. So always remember that if it is normal sinus rhythm, you should know how to calculate the heart rate by just seeing that ECG. How do we do that? Any idea? How do we do that? How do we calculate the heart rate? Normally, we all know that in adults, the heart rate should be anywhere about 60 to 100 beats per minute, right? And one more thing I want to add, when P wave is forming, your electrolytes are working too. So now see Uh, how interesting the name is, electrolytes. Electrolytes. They're the one they are supplying the electricity. That's why they are electrolytes. They're generating electricity in our body. So electrolytes are super, super important. When your atriums are contracting, think about that most likely it's your calcium who is working behind it. They are also working at cellular level. So atriums are predominantly controlled by calcium, whereas ventricles are controlled by your super, super important electrolyte. Which one is it? Potassium. Ventricles. Okay, that's another one. So that's why, because potassium is the one, if it goes low or high, hypo or hyperkalemia, it can cause or affect your ventricles, right? We don't want that anytime. We want potassium should be in normal range because that can also affect our heart rate. Sometimes we cannot really distinguish between if it is ST segment elevated MI or if it is due to hyperkalemia, because in hyperkalemia, ST segment is also elevated. So how do we do that? How do we know that whether it is MI, heart attack, or whether it is your potassium issue, hyperkalemia? We have to run further more tests. For MI, we know all those cardiac biomarkers. What are those? Think about your troponin. We do have different types, IT, right? Troponin, and then CKMB, myoglobin, BN. Do we see BNP, by the way? No, right? That's for the heart failure. BNP is for the heart failure. So we use those cardiac biomarkers from there. If there is any issue, we can see if it is MI. And at the same time, we have to run electrolytes. We have to check labs too for the electrolytes, specifically potassium. If it is high, maybe that's the reason it is causing STEMI. So if it is high, if potassium is high, we need to do treatment accordingly. We cannot be like, oh, ST is elevated, oh, it is heart attack. No, it could be hyperkalemia too. So accordingly, we have to run so many labs, so many tests before we do our treatment, right? We have to diagnose the patient correctly. But who can interpret these lab values? Us. RNs can interpret those values. But if you're LPN or RPN, can you interpret those lab values? Maybe you have nice knowledge about it, but as per your NCLEX, as per your books, they say like it does not come under your scope, that's okay. But if you actually work on normal floors, because I do work in hospitals here and I see RPNs, LPNs, they're working same level. Sometimes they're working more than us, more than RNs. Because in a hospital, we all are working together. If you work in nursing homes, so it's just your RPNs or LPNs who work the majority of the practical stuff, but RNs, they're the one who just sit there and do the documentation part. So that's the reality, right? But if you work in the hospital, I have seen like when I got my first job, I want to tell you this. So there were RPN who gave me the orientation. Otherwise, as per your books, it should be RN to RN, right? So it was RPN who was giving me the orientation, but that RPN was like in that hospital setting from last 20 years. So that depends on experience too, right? So RPNs can deal with a lot of stuff if they have nice knowledge, if they're experienced. Okay. All right. So going back on normal sinus rhythm, what are the other things I want to add here? Okay, yeah. Next part, normal sinus rhythm. How to calculate heart rate from normal sinus rhythm by just watching this electrical, like this ECG strip. By the way, some people call ECG, some people call it EKG, both are same. Okay, ECG, EKG, same. So if they give you 6-second strip and you have to calculate the heart rate, first of all, determine whether it is regular or irregular. Always this is going to be the first question that you should be asking yourself. Is it regular or irregular? What do you think? For regular, how do we say that this is regular? Look at that gap between R to R. R to R, right? Gap is same. So it's a regular. So QRS is forming at same interval, regular interval. So that's why we call it is a regular rhythm. And PQRST is there. So it's a sinus rhythm. It's a regular, it's a sinus rhythm. So of course, we will call it sinus now. How to calculate heart rate? So there is a formula, write it down. So formula is 300 divided by, any idea? 300 divided by number of boxes between R to R interval. Okay, number of boxes between R to R interval. So if you see here, what do you see? First of all, regular R to R, how many big boxes? We're thinking about, here I have to specify big boxes, not small boxes, big boxes. So think about those bold lines. So I'll take the last one. Look at that. Oh. So 1, 2, 3, and we have a little bit here and a little bit here, right? So how much we can think of R to R space? So approximately 4 boxes, 4 boxes. So from R to R, we have big boxes, which is 4. Even though if it is half, calculate it and figure out if it is like full box length or maybe half or maybe half of the half. Okay, so here we get 300 divided by big boxes are 4. So you can get the calculator. Let's see. 300 divided by 4 is 75. Now, is 75 normal heart rate? Yes. 60 to 100 is normal, so 75 is normal rhythm. So this formula can be used when your rhythm is regular. Regular, okay? So now, if the rhythm is irregular, so now how do we know this is irregular? Look at this strip. Look at that gap between R to R. Sometimes it's less, sometimes it's wide, right? So now one thing we know that this is irregular rhythm. Irregular because we cannot locate that R to R. And then look at that. Can we locate P wave? No, right? This is some kind of dysrhythmia. But again, if we have to calculate heart rate from this kind of irregular rhythm, then what kind of formula do we use? We cannot use that big boxes one. Here, we will see now, because sometimes we cannot really locate P wave. We don't know. It's like blending in there. We cannot say like where is T wave and P wave. Instead of P wave, it's just like waves. And we have done in the previous slide that if it is waves, we call it atrial fibrillation, right? AFib, which is irregular rhythm. So most likely this is irregular rhythm and that is atrial fibrillation. But how do we calculate that rate? So count this R to R. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9. So if you count it, so just simply we have R to R, which is ventricular rate. We are only thinking about ventricular rate because atriums, they're just quivering, they're just shivering. We cannot see like how much rate they have, how much like how fast they are beating, right? So 9 into 10 is going to be 90. So that is called, if you only specify this R waves, that is your ventricular rate. We cannot say like it is normal sinus rhythm. We are specifying now that it is ventricular rate. And if you can really locate, for example, you can see P wave. Now calculate those P wave. But your rhythm has to be irregular. Only then we will be able to apply this formula. So think about, you see one P wave here, maybe second one here, maybe third one here, just for example. Fourth one is somewhere here. If you find those P waves, then calculate how many times we get 4 into 10. So then your atrial rate will be only 40. 4 multiplied by 10 is 40 beats per minute. Right? So we have two formulas. One is for regular rhythm, where we have 300 divided by big boxes in between our 2-hour interval. And then second one is we have irregular rhythm. Does not matter which one is it. Could be atrial fibrillation, could be V-wave, could be anything, right? So we can use this formula to see like how fast those ventricles or how fast the atriums are contracting. Easy. So that is your normal sinus rhythm. Now, can you calculate? This is the activity. Can you calculate the heart rate here? Ask yourself, first question, is it regular? Do we see PQRST? Is it sinus rhythm or no? What do you think? Sinus bradycardia, but how much the heart rate do you see here? Forty? 35? 38. Okay, let's see. So first of all, see, do we see PQRST, 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 and then PQRST? So one thing is sure that this is like PQRST is there. This is sinus. Before we call it sinus, we have to verify the other second part too. So think about this gap between R2R, between R2R. It's kind of same. So now one thing is sure that this is sinus rhythm. Now, is it normal? Is it like it could be sinus rhythm, can be normal, can be bradycardia, can be tachycardia, right? So now let's see. 60 to 100 is your normal rhythm, right? So from here, big boxes. We have 1, 2, 3, 4, 5, 6, 7, 8, and then we have a little bit here, 8.5. So what is the formula we have? 300 divided by 8.5, right? 8.5. So how much do we get? So 300 divided by 8.5. We are only looking large boxes, right? So 35 point something, 35 point something, 35.29. So I'll say that it's 35 because beats cannot be in decimals, cannot be in fraction. We all know. 35 beats per minute. So 35, which is your bradycardia. So we have this term, this rhythm as, we can say it as sinus bradycardia. Okay. So can you calculate this rhythm for me? So we can see PQRST, PQRST, we can localize it. And from R to R, ask yourself, is it like the gap is same? Yes, the gap is same. It is regular. It is sinus rhythm. Now calculate, try to find out those big boxes here. Big boxes. So we have, let's take this one. So we have one big box, oops, one big box, and slightly here and slightly here. So I can say that 300 divided by 2.5, even though it's 0.5, calculated. So in between 2, 1, so here we have slight here and slight here, right? So 2.5. So it cannot give you the exact heart rate, but it can give you the approximate heart rate that it could be in between this one. And that way we can have an idea if our patient's heart rate is up or down. So 300 divided by 2.5 is going to be 120 and normal is your 60 beats, 60 to 100. So it is going to be treble 1, right? Sinus tachycardia. Sinus tachycardia. Now, can you calculate it? Ask yourself, is it regular or irregular? Look at the gap. That is the first question that you want to ask. So look at the gap. Too much, again too much, less, again wide, too much. So this is irregular. So when you have irregular rhythm, we use different formula. So now, can you calculate the rate? So now just pick those R to R. So how many R's we have? 1, 2, 3, 4, 5, 6, and then 7. 1, 2, 3. So 7 multiplied by 10 is equal to 70. We have approximately 70 beats per minute, but rhythm is irregular. It's not sinus. So irregular rhythm can be normal range, in normal range, but that is irregular, right? Sometimes ventricles are beating fast, sometimes they are slow, sometimes they're fast, right? So that way we can see what is happening. So now let's talk about normal sinus rhythm. So how we are progressing towards now from here. So we'll do normal sinus rhythm, sinus bradycardia, tachycardia, and then we will talk about atriums related dysrhythmia and then ventricles related dysrhythmia. So this is normal sinus rhythm. Okay, so we already know this. That always the normal sinus rhythm should follow SA, AV, and then all that electrical conduction. SA node is the origin. Normal heart rate is 60 to 100. Everybody knows that. And there could be sinus bradycardia, which can be sometimes normal. And that sinus bradycardia is normal in athletes. Because athletes, they do running. So for them, their baseline sometimes goes like normal, even though if their heart is at 55, but if it is normal, if they do not show any sinus symptoms, no any sinus symptoms, they're okay, they're perfect. Their level of conscious is okay. So that means that is normal for them. That is their baseline. That's okay. But if they are very much symptomatic, then we need to think about it. Then we should take care of the person, because if it is sinus bradycardia, think about heart is pumping slow, we don't have enough cardiac output, we don't have enough blood to perfuse our vital organs. So that could be problem. So sinus bradycardia is always due to these medications. Sometimes we do vagal nerve maneuver or athletes. For athletes, as I said, it is normal. But if it is due to medications, what kind of medications are there which can slow down the heart rate? Tell me. Digoxin is one of them, right? Digoxin, we did that. Digoxin. Beta blockers, they do reduce heart rate. Right. Beta blockers, your calcium channel blockers. Does your ACE inhibitor drop the heart rate? Think about ACE. ACE inhibitor, which is your angiotensin converting enzyme inhibitors. Do they affect heart rate, or it's just blood pressure? It's just blood pressure, right? ACE, the one that we use in heart failure. So they do not drop heart rate. So if on NCLEX, if you get questions on like, patient is using ACE inhibitors, don't think too much. It's okay, because it's not going to slow down the heart rate. But if your client is using, let's say, carvedilol, what is carvedilol? LOL family, your beta blocker, that can be the one who can cause bradycardia. So always figure out if the patient is symptomatic, and there could be a lot of causes which can cause sinus bradycardia, and figure out the cause. Which causes it, and remove that, eliminate that cause. Okay, carvedilol is the one who can drop the heart rate. How about if I say levothyroxine? Let's say if this patient is taking multiple medications, ACE, which is your ramipril, carvedilol, levothyroxine, or maybe think about glimepiride, which is your oral hypoglycemic agent, glimepiride. We give to type 2 diabetic patients. Okay, so which medicine? Patient, of course, patient with aging, they have polypharmacy issue, right? They will be taking a lot of medications, because with aging, they have lots of issues, diagnosis. So for that, they're taking multiple medications. So we already know that a lot of drugs, they do drug-to-drug interaction. So we need to think on that too, that which medication is specifically causing this. And then do your assessment. And as per your S-bar protocol, we can talk with our doctor. Tell them that this is what's happening with our patient. So do you still want me to give this medication, or you want me to hold it? Right? We can recommend too, as per your S-bar. We can recommend too. But do your assessment, do your critical thinking stuff, be that nice detective nurse, and then we can save our client. Okay, so it's carvedilol. Maybe we need to withhold. Maybe doctor can prescribe something which does not affect heart rate at all, because client can go in sinus bradycardia. So this is how we can manage, right? I always assess the cause. Sinus bradycardia is important because it can reduce the cardiac output. We need to remove that. Okay. So there are other medication, digoxin, beta blockers, calcium channel blockers. So if patient is on them, so hold those medications. And if it is athlete, as I said, it is normal for them. So for sinus bradycardia, these are very important protocol. So first thing we want to make sure, is it our client's baseline? If it is baseline, they will be asymptomatic. If they are asymptomatic, do we need treatment? Let's say on the screen, it is saying that patient is having heart rate 50 beats per minute. but patient does not show any sign and symptoms. They're okay, they're fine, they're talking, they're working, they're not feeling dizzy, they're not fainting. Do we need any treatment? No. So that's baseline for them. They're working on that, even though like the heart rate is down. But if the client is symptomatic, so symptomatic includes what? So first of all, heart rate is down, symptoms are present, and symptoms are due to bradycardia. Sometimes it's due to some other issue too. Sometimes if it is hypothyroidism issue, sometimes they feel dizzy because of that. But if it is due to bradycardia, if those symptoms are due to bradycardia, we need to give the treatment. Okay, patient may feel like lightheaded, dizzy, patient may fall, patient may feel hypotensive, shortness of breath, unresponsive, maybe they're pale, they're cool, altered mental status, syncope. So we must treat them because bradycardia causes a lot of signs and symptoms. We need to treat them. How do we treat them? What are the major medications that we have? First one, only if patient is symptomatic due to bradycardia, give them atropine. Okay, atropine will spike the heart rate. But other than that, just know atropine is having secondary action as well. Primary action here, we're thinking about primary here because it will spike that heart rate up. But another thing that atropine can do, it is anticholinergic as well. Atropine is anticholinergic. And we all know what does anticholinergic means. Anticholinergic, dry out the secretions, right? Cannot be given in glaucoma, cannot be given in if patient is having constipation. Can we give atropine to pregnant ladies? No, right? It is contraindicated. If somebody is already having urinary retention, can we give it? No. Atropine cannot be given because it can cause or worsen more like urinary retention, can cause urinary retention. So anytime patient is having glaucoma, GI obstruction or constipation, urinary retention, if they're pregnant, do not give this. But now, if we have to give it, so atropine is your first choice, then we have dopamine and epinephrine. So those are the three major medication which can be used to treat sinus bradycardia. And for atropine, we use 0.5 milligram IV. And we will see. We will monitor our patient. We have to be at bedside because you're giving something IV and we need to assess that. We cannot leave our client like that. If you're leaving your client like that, you're going outside and treating other patients, maybe something happened to our client and you are accountable for that. If you give something, it's not that you gave something and you're done. No, you have to stay with the patient, make sure that they're safe. If there is something else, report to the doctor right away. Because for anything we have to do, like we need some order, right? So 0.5 mg IV, so we can repeat it every 3 to 5 minutes, every 3 to 5 minutes. And maximum we can give is 3 mg. So 0.5 mg, so 0.5, 0.5 every 3 to 5 minutes. So that means it can be 1. So it can be given like if you say like maximum is 3 mg. So if you multiply 0.5 into 6 doses, that will be 3 mg. So maximum we can give to any client is 3 mg, not after that, because you will see no any effect afterwards. Okay, you will deteriorate the condition. And if you really have to give epinephrine, it could be 2 to 10 microgram per minute or dopamine 2 to 10 microgram per minute. Just know these are your emergency drugs, always in your emergency crash cart. From there, we will see that. And if they are emergency drugs, the patient is really critical, right? That way, it's not like normal issue. Sinus bradycardia is very normal. No, the patient maybe have to be in ICU because they're critical. So epinephrine, just know whenever you see epinephrine, dopamine, the patient is critical. The patient may be in the ICU. Okay. So that is all about your normal like sinus bradycardia. So this is your sinus bradycardia. If you have to calculate the rate, how much will be the rate? First of all, you see the same gap, right? R to R, and we can see, can we see P wave? P, Q, R, S, T. And then P, Q, R, S, T, right? But very slow. So it could be below 60, but how much is it? If you see those big boxes, look at those big boxes. So 1, 2, 3, 4, 5, 6. So 300 divided by 6. How much is it? 300 divided by 6. 50. So that's bradycardia. So if you see this strip, If on NCLEX exam, they gave you the strip, for example, they give you the strip and they told you that patient is talking, patient's strip was this, patient is eating right now and talking. So patient is fine. Patient does not have any symptoms. We only worry about someone who's having symptoms. So if you see 50, but patient is okay, we don't need any treatment. But if patient is symptomatic, if they feel dizzy, if they're fainting, so we need treatment. And what is the treatment? So atropine, those emergency drugs. Okay. So next is your, I will skip it, identify this rhythm. So that way we have sinus tachycardia. So is this tachycardia? Can you see P wave? First of all, is it regular rhythm? Ask yourself first question, regular? Looks like regular, like R2R interval is like same. Now, another question, can you see P, Q, R, S, T every time? Yes, right? So this is sinus rhythm. But if you have to calculate the rate, so between R to R, if we see this way, so one big box, two big box, it's just like two boxes, 300 divided by 2. Or if you see this one, maybe pick 2.52. So one box, and then half. So 2.5. What will be the rate? 300 divide by 2.5. 120. That is definitely your tachycardia, but sinus tachycardia, right? Because we have regular ECG. So when do we have sinus tachycardia? There are so many causes which can cause sinus tachycardia. When the beat goes, normally 60 to 100 beats per minute. When it goes more than more than 100 beats per minute. 100 beats per minute. And that could be due to pain. Sometimes when you have some sort of like too much pain, that time automatically your sympathetic nervous system gets activated because you are in stress. And when you are in stress, your sympathetic nervous system activity goes on, turn it on, and then heart rate and all the systems goes crazy. So you're in pain, you are in stress, you are in anxiety, you are in can you pick dehydration? In dehydration, do we see tachycardia or bradycardia? Dehydration is very important. Anytime your client is having dehydration or anemia, pick tachycardia. Tachycardia. If you are consuming, let's say, a lot of caffeine, coffee all the time, tachycardia. Think about hyperthyroidism. That's itself a condition where all the system goes crazy high. So they operate crazy high, hyperthyroidism, heart rate will be crazy. So you'll see tachycardia. How about if somebody is using illicit drugs, or I would say CNS stimulant drugs, which are your amphetamines, methamphetamines, brand name is Adderall and Ritalin, right? So those are stimulants. They cause heart rate really high. Some people, they use some fancy drugs called street drugs these days. They use like something called magical mushrooms. Magical mushrooms are stimulant too. They do not induce sleep. Instead, they do heart rate crazy high. Smoking itself, right? So those things can cause sinus tachycardia. We need to figure out what is the underlying cause, fix it. And how do we fix it? First of all, remove the cause. And if you need pharmacological treatment, what will be the treatment? Think about your beta blockers. Beta blockers. We can give beta blockers. We can give calcium channel blockers. If you have to specify beta blockers, what are the specific one? Think about this mnemonic, MAL. That is your metoprolol, atenolol, labetalol, which drops your heart rate, plus they reduce the blood pressure too. But some beta blockers, they cannot be given in the respiratory patients because beta blockers, they do bronchospasms too, right? bronchospasms. How do they cause? We all know that beta blockers again are of two types, selective and non-selective. So selective, they are selected for the heart. Non-selective, those receptors are everywhere. But specifically, if we have to think about, they are in lungs and in the heart. So if we try to block that activity of those beta blockers are belong to the, think about your SNS activity. When you are in that stressful condition, which response of the body is getting activated, that is your flight or fight, right? We all know that fight or flight. PNS is your rest plus digest. So now we need to stop this activity. Beta blockers, they are working with sympathetic nervous system. So we're trying to block it. So when we are trying to block it, it will reduce the heart rate down, putting everything down. But think about when, I always used to give this example to my students. What happened, like, if there's line behind you and you're running, you're of course in stressful condition, line is behind you, you wouldn't get escape, right? You want to save your life. What can happen? Your sympathetic nervous system is getting activated. So heart is pumping high, heart rate will be extremely high. And that time, think about all the head to toe organs. Brain is working hard because brain wants to hide somewhere. So all this like work is very fast in the brain, and then heart activity is high. Heart is pumping fast so that it can provide blood supply to the vital organs, so that vital organs can work faster. And on the top of that, think about the lungs. So we need more oxygen. So in sympathetic nervous system, bronchi, that airway get expanded because we need to have more oxygen. So always know that in fight or flight, bronchi are getting expanded. But if you are trying to block that activity, so bronchi are going to get constricted. So we cannot give beta blockers really to someone like which are non-selective one, which are present in the lungs. So think about your asthma patient or COPD patient. We cannot give beta blockers in them. Make sure that you get the history if this client is having asthma or COPD or any obstructive disorder, any lungs-related obstructive disorder, we cannot give them beta blockers because it will constrict the bronchi. Okay, I hope that you remember this line example every time when you think about sympathetic nervous system. All right, so think about it, and we will try to not give those drugs to those patients. Okay. So next is sinus tachycardia. I think we have done that. What kind of treatment do we need here? Sinus tachycardia. But again, if line is behind you, heart rate is going up, do we need any treatment for this client? Because that tachycardia will resolve once that stress is gone. So we don't need to think about a lot. But if sinus patient is in sinus tachycardia and showing a lot of sign and symptoms, what kind of sign and symptoms? So because heart is pumping fast. So what about the cardiac output? It will be high or low. Think about heart is pumping, heart is not having enough time to relax. When they relax, only then blood is filling, right? But it is pumping fast. It does not have enough time to relax and get filled with the blood. So now what happens? Cardiac output will be less, right? Heart is pumping like fast. So cardiac output will be less. So no doubt BP or heart rate will be high, but output is less. So maybe we need to give oxygen to the client. Okay, we need to have IV access. Maybe we need to give something IV to drop down that ECG and notify to the doctor. Those are important points. Sometimes, like someone said, shock is, or sometimes patients are in sepsis, infection is super high in the body is under stress, and those things can really cause sinus tachycardia. SSRIs and MyoEs cause sinus tachycardia, not really, but MyoEs, they affect your blood pressure. That is more important. And sometimes my mother, she takes SSRIs. Her heart rate is usually high. It could be like we really have to figure out whether like your patient is having some other issue or no. Sometimes like people, they have other conditions too. But directly, if I have to say MyoEs, not really. They affect because they contain that tyramine substance in it. So they affect the hypertension. Okay. But they will be sweaty when they use a lot. Those SSRIs, they will be sweaty and palpitations are there. So, but they're not like the one which can worsen the issue, right? So we're only worried about caffeine or CNS stimulant drugs. SSRIs are stimulant too because they put the energy in the patient. So can cause, but it cannot be like life-threatening one. Um, Okay. So any question on here? So treat the cause if there is any fever or if they're using any caffeine or like CNS stimulants, pain or anxiety, sepsis, anemia, hypotension can cause sinus tachycardia. Even sometimes MI can cause sinus tachycardia, heart failure because compensatory mechanism when heart is not pumping fast and brain is getting signal that we don't have like a enough oxygen. All the other body parts, kidneys are not getting enough oxygen because heart is failing to pump. So now brain will send the signal to heart, pump faster because you are going out of control. You're very slow, pump faster. But heart is failed already. It will be like heart rate will be fast, but we will not see much cardiac output in heart failure. Okay, hypoxia, compensation, compensatory mechanism, body sensing, we have low oxygen. Brain is telling the heart to pump faster so that the other vital organs can get oxygen. Okay, so sinus, these are the ECG features we have already discussed. Regular rhythm, PQRS is there, narrow QRS sometimes, and then rate is going to be high. So let's talk about atrium dysrhythmias. I'll be very quick because atrium dysrhythmias are basically two. One is atrial fibrillation, which we have already discussed, and another is atrial flutter. Okay, so if you see this term, atrial fibrillation, first of all, do your maths again, do your questions. Is it regular? First question, check the gap. Check the gap. Sometimes wide, narrow, wide, narrow. So R2R interval is not regular. That is first thing. This is irregular. And second thing, can you look at PQRST? Not really. We do have QRS, but can we locate P waves somewhere here? Instead of P, it's just waves. So now what? Now what? We will see no P wave. So that means that clearly, when you see this criteria, these two things always pick atrial fibrillation. Okay, first of all, this is irregular rhythm. Second thing, we cannot locate P wave. Instead, P wave, it's just quivering, shivering. So what is happening? Think like, imagine atriums have to contract and push the blood to go down in the ventricles. But now atriums are not doing their part. Atriums are like just shivering, shivering, shivering. And blood is staying there for long, long, long time. Now, treatment is going to be very important. If blood is staying there, atriums are not contracting, blood is staying, staying, staying. It can form clot, right? And one thing is clot issue, and that clot can travel anywhere. It can go in lungs and can cause PE, pulmonary embolism. It can travel in the brain and can cause stroke. It can go in the renal arteries and can cause renal infarction. Can be very life threatening, right? So one is stroke. Second thing, if atriums are not working, ventricles are working fine. That's why we are getting QRS complex, but that's irregular, right? But ventricles does not have any issue. They are pumping, but at irregular rate. But are they getting enough blood from the atriums? No. Do we see enough cardiac output? No. Are our organs getting enough perfusion? No. So see, there are two issues. One is cardiac output related. Maybe the body is not getting enough oxygen, oxygenated blood, perfusion. And one is stroke. So those are important, major important. So pay attention to the treatment. I'm going to talk about that. So any issue with the atrial fibrillation? No, right? Okay. So before I do the next one, I have to focus on this atrial fibrillation. So there are two things which are very important. One is the clot. Second is body is not getting cardiac output, or I would say oxygen is low. It's going to be low, of course. Body is not going to get oxygenated blood. So treatment is going to be super, super important. And if you have to calculate the rate, what will be the rate? Look at that. R 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So 12 into 10, because we cannot locate atrium. So that's why now we will use this formula. So 120, which is high. So atrial fibrillation, you will see atrial rate is going to be high, but ventricles are contracting, but very fast, but irregular. So always rhythm is going to be high. Majority of the time, AFib rate is going to be high. Ventricular rate is high. Atriums are quivering, and if you have to really see, or let's say if we are guessing, there are like 3, 4, 5 ECGs, and calculate there could be a lot. So atriums are like shivering, like it could be like 300 beats or maybe more, but we cannot locate that, right? We cannot really like guess, but on a guesswork, we can think like atriums are just shivering. So what will be the treatment? That is more important. So this patient, they need anticoagulants for sure, coagulant to remove those clot, and we have less cardiac output. We have to give them oxygen, right? Oxygen. There are two important things. And how do we give like anticoagulants? We already have talked about, those are who are our students. We already have talked about heparin and warfarin. So how do we give them? We give them both together. Now you must be thinking, oh, why two anticoagulants are being given to like both together? Why? Because warfarin will not act right way, and warfarin, the other name is Coumadin. So Coumadin is the one which can be taken like orally, oral tablets. Okay. So heparin is very fast acting, and it does have short half-life. Warfarin, it does have long half-life, and it can stay in the body for long, like long time. So warfarin, if you're getting warfarin today, you will not see the effect right away. Maybe you have to wait 4 or 5 days. So that's why we have to really take heparin and warfarin together so that we can see immediate blood thinning effect. And once warfarin kicked in the body, how do we know that warfarin kicked in the body? So we know by INR. So INR, in you and me, we are not on the warfarin therapy. In you and me, it is 1 to 2. But if somebody is on warfarin therapy, it has to be 2 to 3. But again, another condition. If somebody is having any prosthetic valve replacement, then we add 0.5, 2.5 to 3.5. So that's the max, right? So heparin. For heparin, what is the coagulation profile time that we check? That is your activated partial thromboplastin time. And what is the normal one? Let's see. What is the normal APTT time? In you and me, when you are not on heparin therapy. No one? Come on, guys. 70 seconds. Any other guess? 15 seconds? No, that's very less. Always take the range like we did in INR. Go heparin. 30 to 60 now. So APTT is your activated partial thromboplastin time. So it should be, some book says 25 to 35, some book says 25 to 45. Okay. So it should be in you and me. We are not on heparin therapy. Normally it has to be 25 to 35. But once anyone is on heparin therapy, we multiply it by 1.5 to 2.5. So then if somebody is on this therapy, take the higher range, multiply 2.5 with 35. But how much do you get? 35, 35 multiplied by 2.5. So anyway, 87. Some book says that. So I would say keep it like not short. We need less than 75. If it is more, that means client is at high risk of bleeding. If the time is really, really too much, that means our body is taking too much time to clot or to stop the bleeding. If that time is not in that range, if it is very less, then body is making clot. So if time is low, body is at high risk of clot. If time is too much, that means body is taking too much time to stop the bleeding. That means client is at bleeding risk. Okay. So heparin. So we give them together, and then when you give them, we really have to watch this time frame. Okay. So 1.5 for some books says 46 to 70 or 70. Let's keep it simple. 45 or 46 to 70 seconds. If somebody is on this heparin therapy, okay? So we have to really watch this time and also make sure that heparin cannot be given for like more than 1 week. It can be given only for like 3-4 days. And if you keep giving it, it can cause one complication. Which one is it? Complication. Come on, guys, we did that. Perfect, Mehak. Thank you. So it can cause HIT. What is HIT? Heparin-induced thrombocytopenia or thrombosis. So that's the reason whenever you give heparin, do not only focus on your APTT time, because thrombocytes means your platelet level can go down or can go up. Thrombocytopenia means platelet goes down or can go up. If they're going down, platelets going down, bleeding risk. If thrombosis is there, there is clot risk. So heparin-induced, these both conditions can occur. So we really need to see the platelet count when your client is taking heparin. That's the reason, right? Okay. So I think I have explained like why do we start these things together, and if the time goes like let's say client was on heparin and right now the APTT time is like 90 seconds. So what do we need to do? Think about. Always assess the patient first, right? Stop the medicine. Anticipate the antidote, and antidote is what? For heparin, the antidote is what is it? Protamine sulfate. Thank you. Protamine sulfate. Is it vitamin K, Tanya? Sulfate for heparin. It's protamine sulfate. And for warfarin, we do give what? For warfarin, we have like vitamin K. And another name of vitamin K is for warfarin, vitamin K or phytonadione. So those are the things. But anytime if your client is on anticoagulants, make sure that you put the client on bleeding precautions. Teach them. Teaching part is very important because with the teaching, you can really save your client. And teaching, who can teach the patient? Us as nurses. So always use the soft bristle toothbrush. Do not use those razors. Instead, use electric razors. They do not do abrasions or lacerations or the micro tears in the skin. So teach them about if they're staying in the home safety. For example, if this is the area, it should be clutter-free area. There shouldn't be anything in between. If they have to wake up at nighttime, if they have to go to the washroom, make sure that area is clean, right? No thrown rugs. There should not be pets because pets can come in between and the person can fall. And if they are on anticoagulants and that can cause massive bleeding, can cause hemorrhage, shock, right? So we have to put the client on bleeding precautions. If bleeding does not stop, again, those people who are on anticoagulants, they should be given with the bracelet, safety bracelet. For example, this client was on anticoagulant, they were on highway, they just had accident. So if they have bracelet, if ambulance, your paramedic staff comes, if they see that, they know like what to do. Anticoagulant is there, maybe they will think about antidote. They'll give that antidote right away and it will stop bleeding. Okay, so that's why those medic alert or safety bracelets are very, very important to wear. Okay, and make sure that if anyone is having or is on anticoagulant therapy, if they're going for the surgery, know what? They should stop taking anticoagulants before the surgery, and make sure that there are some herbal medications too, herbs. All those herbs which are starting from ginger, garlic, ginkgo, ginseng, a lot of them. So even the saw palmetto or your vitamin E, they all have blood thinning properties. If anyone is on heparin or warfarin or any anticoagulant, or let's say if they are on aspirin or any blood thinner, they shouldn't be taking herbal medication, because with that, we will be having combined effect, which we call synergistic effect. And then client can have bleeding issues, major bleeding issues. So that's the thing, like there's a term called medication reconciliation. So whenever your client is coming to you, make sure that you take whole history, what kind of medications you are on, take that list. Even though if they're taking some supplements or herbal medications, take that list, so that as a nurse, we can see what's interaction, what can harm our client, teach them. They cannot be taking all these things together, of course, right? Okay. Now, next one. By the way, I have to really talk about vitamin K. If somebody's on vitamin K, on warfarin therapy, and they want to lose the weight, and they are taking lots of green leafy vegetables, and we know green leafy vegetables, they have vitamin K, a lot of vitamin K in dark green vegetables. So teach them they cannot be taking a lot of green stuff, because otherwise they will lose the purpose of having that warfarin, right? Because vitamin K is the antidote. It will cancel that effect. So they cannot take vitamin K related dietary food, right? So they are like all of a sudden they're like, oh, I want to lose weight. So right now they're just taking greens. They're on salads. Morning time they're taking salad. Evening time they're taking salad. They're trying to lose weight. So teach them. Otherwise, the patient will be on clot risk, and we are using in AFib. So clot can happen anytime, and that clot, if it gets travel anywhere, can be life-threatening. PE, stroke, think about that. John Wort, Saint John Wort is for like your depression. Okay. All right, so look at this rhythm. What do you see? First of all, first question, is this rhythm regular? Look at that R to R interval, that gap. Is it same? Looks like regular, right? But now, can you look at P wave? Not really, right? So we have QRS, and then P, I don't know if it is T or P, what is it? So instead of P wave, we have some sawtooth, the seesaw, that one we use for wood chopping, right? So if you see sawtooth, so it gives that sawtooth shape. So this is regular rhythm, but we cannot locate P wave, so there is some sort of atrial dysrhythmia, and we call it atrial flutter. Atrial flutter. And look at that, this is regular. Whereas A fibrillation was irregular. And if you have to calculate the rate, so use regular. This is regular, right? So what will be the rate if you have to see? It is fast again, 300 divided by big boxes. So think about it. Right? So this is another way. So instead of P wave, we just see those sawtooth shape, and in this, the gap is same. Rhythm is like R to R interval is okay, but atrial flutter, like instead we just see those sawtooth shape. So still there is no definitive P wave, right? So now treatment will be same, like the atrial fibrillation. We have to bridge those anticoagulants, because again, atrial flutter, they are just fluttering again. Shivering, fluttering, right? No doubt there is regular rhythm, but it's fluttering. So all those issues are going to be same. So we have to treat it same way, like A fibrillation. Okay. These days, we use a special and new blood thinners, which we call factor 10A inhibitors. I hope that you know that. Factor 10A inhibitors. They're fancy one. They're safe, right? We don't have to really check the coagulation profile time when the client is on factor 10A inhibitors. Like any drug which is ending with Xaban, apixaban, rivaroxaban. There is one exception. We have fondaparinux that is under your factor 10A inhibitor. But Xaban drugs, they're like new ones. They're really safe one, and they're like in the tablet form. And patient who have atrial fibrillation, that's okay. They can stay at home. They can manage everything at home, even though like if they have, because when I work on the floor, my every third, fourth patient, they have atrial fibrillation. When they go in old age, they must be having this. So they already know about their pill schedule, what to do, which pill do they need to take. Okay. But if you are adding new one, and if your client is asking, why am I getting this pill? I have never taken this pill. Can you please make sure, do not argue with the patient, check the order, right? That's what we're supposed to do. Maybe we are wrong, maybe patient is right. Do not say that, oh, it is like prescribed, you have to take it. No, don't be that rude nurse. So you have to again stay with the patient. Okay, your response should be like, okay, let me check again, and then come back. So check that, and then there could be possibility that maybe you are giving wrong drug, right? So pay attention. Patients who have these conditions, they are managing very well. Even at home, they know what kind of medicines they are taking. So if they're talking really about it, asking questions about it, uh, give them nice answers, right? Therapeutic answers. So now, anticoagulant was one. So now, in both condition, atrial fibrillation and flutter, one thing is like rate. Rate was high, right? Rate is high here. So what we can do about rate? We can think about beta blockers. We can think about calcium channel blockers, specifically that diltiazem and verapamil. We can also think about digoxin, right? Digoxin will help for the myocardial contractility, which these atriums are not doing, they're just quivering. So instead, we are giving digoxin, right? And if those beta blockers, calcium channel blocker, digoxin does not work, then we have special antiarrhythmic drug, which we call amiodarone. This is very nasty drug to know and very important drug to know. So when they're taking it, there should be three organs that you should be checking. And what are those three organs? Your lungs, thyroid, and your liver. So you should be checking those profiles, those labs, because they can damage these three organs. So for lungs, you really want to do those pulmonary function tests, see whether lungs are okay. For example, if this patient was taking amiodarone from 1 to 2 weeks, and now right now they're having really shortness of breath, think about that. They're damaging lungs. We need to stop it. We need to teach, or we need to talk with the doctor. Okay, thyroid, it can damage the thyroid. So we need to see T3, T4 if they're going down, right? And if it is going down, it can cause hypothyroidism and then myxedema coma, which is a complication. We don't want that. And liver. So anytime your client is presenting with, let's say, hepatomegaly, jaundice, chronic tears, urticaria, itching. So those are the clues. If client is having, we need to stop it. This is adverse effect, not expected. Okay, we cannot ignore those. And also amiodarone is your very special drug, and people they can have photosensitivity with this sensitivity. If they go outside in the sun, it can burn the skin. So amiodarone teach the client uh, if they can stay at home, that's okay, between 10 to 4, 10 a.m. to 4. If they really have to go outside, make sure that they wear proper clothing because it can damage their skin if they are on amiodarone. All right, so treatment again is going to be same for AFib and A-flutter. So this is sawtooth. Look at that, the pattern. That's why this thing is named as sawtooth pattern. Okay. All right. So that's pretty much about atrium dysrhythmia. I will be very quick because in ventricular dysrhythmia, we have very interesting things to know. Okay, before we finish. So SVT. Um, okay. I have posted one of the video on Instagram on SVT. Maybe if you have seen that, I cannot really log in. Hmm, let's see. No, I cannot. But this is very interesting. Rhythm, supraventricular tachycardia. So if you see this rhythm, look at that timing. If you haven't seen the video on my Instagram page, please go and see that how do we give that adenosine, very important for your exam purpose. So look at that rhythm. Is it regular? First question. Yes, it is regular. But can you really look at P wave? P wave. Can you look at it? Where is the T wave? Where is the P wave? Can we look at P wave really? No. So that's a difference. But in sinus tachycardia, we can really look at P wave and we can differentiate this is the T wave and now P wave is coming in QRST, QRST. But in supraventricular tachycardia, T wave and P wave, they are blending together. We cannot really locate it. Okay, that is one thing. And QRS complex. Think about that QRS complex. I told you in starting, let's go back. What is the timing for QRS complex? Okay, there. QRS less than 3 small boxes, right? Remember that. So that's why I teach you those basic things first. Okay. So now in QRS complex, look at here. How many boxes do we see? Very less, right? Normally it should be 3 boxes or maybe less than that. So now it's sometimes 1 or not even 1 or sometimes it's 1.5 small box. So it's QRS is very narrow, very narrow. That's very important key factor. Okay, sinus tachycardia. First thing, rhythm is regular. Second thing, can we locate P wave? No. Third thing, QRS complex is very narrow. If you see these 3 things, this is your SVT, supraventricular tachycardia. What is that? Supraventricular tachycardia. It's not a sinus rhythm. It's abnormal rhythm, but it could be sometimes due to, look at that rate, very high. So supraventricular means anything above the ventricles, so the origin is there. So maybe it's AV node, which is firing like really fast, and you see narrow QRS complex. So stimulant, hypoxia, stress exertion, hypokalemia, CAD, those can be the causes. And then special, again, we did that WPW, right? Wolf Parkinson White syndrome. So that can also cause SVT, where you see those abnormal circuit. So it's between ventricles, in between the ventricles, which are originating those abnormal circuits where they were bypassing the SA node. So it was in the circuit. So WPW can cause SVT or accessory pathways are there. So that's why we are getting supraventricular tachycardia sometimes. But other than that, these can be the causes. And if your NCLEX is asking question on select all that apply, make sure that you pick these. Okay. And treatment wise, never ever pick pharmacological as your first resort. So your initial, once you know that maybe on NCLEX they give you the strip, and now you know that this is SVT. So they have asked, okay, identify the strip and what will be the treatment or what will be the initial action or priority action, initial priority. So what we can do, we have to do Valsalva maneuver. Oh, sorry, vagal nerve maneuver, vagal nerve. When we stimulate our vagus nerve is the largest nerve in our body, right? It is going all the way from mouth to brain to the rectum. So if we stimulate that nerve, it can drop down that heart rate. Maybe you have experienced the constipation in your life. Of course, everyone does. So if you try to strain, because when you have constipation, you try to strain. And when you strain, have you ever noticed that your heart rate goes little like crazy high? Right? When you strain, heart rate goes little high. So that's the time when you see, sorry, it is not going high. So when you stimulate vagus nerve, it is going down. When you really strain, it should be like slow, and then after some time it goes high. It slows down. So in SVT, your first priority is to stimulate vagus nerve. Vagus nerve, okay, someone said PNS. So parasympathetic nervous system, it activates parasympathetic nervous system tone. So we know rest and digest is slow down everything. So it will slow down that heart rate. Very interesting. How we can do that? We can maybe massage that carotid pulse, sorry. But in babies, we cannot feel that carotid area because babies have small neck. So what we can do in babies, best thing, ice face, ice. Maybe if it is adult, sometimes supraventricular tachycardia is there, patient is kind of awake, they can follow the command, they're not like unconscious like fibrillation. So they can be awake. So what we can do, like if patient is awake, so have them to immerse their face in the ice water, in the cold water. That way we can stimulate the vagal nerve and heart rate can go down. Another way in the babies cannot follow the command. So maybe on the nasal bridge, we can put some ice on there, here, that can innervate the vagus nerve and slow down the. I have seen very interesting videos on Instagram too. So if patient is on SVT, in SVT, so they give some syringe and then the person has to blow very strong so that they can push that plunger back. So they have to blow like strongly. So blow strongly. So that one which we call is like, when you do that, we're trying to strain here. Try to do that. When you hold, like try to hold, or when you try to blow, think about this as like syringe and you're trying to blow, feeling that you can push that plunger back with a blow. So you can strain muscles here, and that way we can stimulate our vagus nerve and slow down that heart rate. So this is one of them. Ice face, gag reflex, cuff. We can have them cuff, and Valsalva maneuver. Everyone knows how to perform that. Strain the abdominal muscles, right? So Beer, I don't know your exact name, but yes, you have, maybe you have seen those series, and in those series, you might see those things. They do that. Okay. So now those are the ways where we can really help the client. If they're having SVT, we can stimulate that carotid nerve, and we can save our client, right? But if those things are not working, they are all non-pharmacological methods, but if they are not working, then only think about adenosine. So adenosine is your drug of choice. But on NCLEX, if they give you the strip and then like they give you, for example, 4 drugs and you have to really pick one. So adenosine is one of them. This is very interesting drug. Very interesting drug. That's why I wanted to show you my video, but I can't. That's okay. But adenosine, how do we give that? Maximum can be given up to 30 mg, but how do we give them? Maximum 3 dose. First dose, as per your ACLS protocol, 6 mg. If that does not work, then 12 mg. If that does not work, 12 mg and 3 dose maximum. And if you have to calculate 12 plus 12, 24 plus 6, 30 mg in total. 30 mg is total, that's the max. And how do we give that? So that's interesting. So we have 2-way cannula. So in one syringe, we have adenosine, and in another syringe, let's say, do we have anything here? So in another syringe, we have normal saline, 20 ml. Why do we need normal saline? Because adenosine acts very fast and its half-life is like 6 to 10 seconds. When I say half-life, means it can show its effect very fast in seconds, and it can be excreted out from the body or can be disintegrated from the body. So if you give like adenosine IV push, for example, 6 mg, it could be, let's say, 1 to 2 ml. So if you give that IV, rapid IV push with, and when you say rapid IV push, it has to be within 1 second or 2 seconds. It should be like very fast, so that we can keep that going to the heart. And what kind of veins we have to pick for adenosine? Any vein which is very close to our heart, left side. So if you have central line, pick that. But if you have antecubital or anywhere like in the peripheries, you have to really think that it is going to be wasted very soon. So soon after you give that, make sure that you give 20 ml right after that, so that this drug goes directly into the heart without wasting much time. So 20 ml push is very, very important. If you don't do that, medication will stay in the veins and it can be destroyed and it will not reach to the heart. So that's why we have to be like very fast when you give those medicines. So two syringes, we have to prepare them before you give them all together, and then you will see funny things, interesting things, not funny, I would say interesting things on the cardiac monitor. What are those interesting things? As soon as you give that, you will see asystole kind of things. That is for small time, for few seconds, maybe 1, 2, 3, or maybe 5 seconds, you'll see the flat line. So sometimes patients are awake or family is there and they'll be like, oh, patient is having beep, like beep, asystole, flat line, or something is happening. Tell them it is going to be happen and that is expected. So that is the expected effect of adenosine, and that is planned action. We want, why it is happening? Adenosine is trying to reset the rhythm, that abnormal circuit that I told you in WPW. So adenosine is trying to block that abnormal circuit and reset it normal. What is normal? From AC to AV and then from there, right? So very important points. And if those things does not work, then cardioversion. Cardioversion, I would say, in between, if we have to think about cardioversion, and then we have defibrillation. Defibrillation is like major shock, where those joules, those energy, those voltage is really high. Cardioversion is like baby shocks. Okay, so we use cardioversion in every arrhythmia. If think about atrial fibrillation, atrial flutter, if medications does not work, if patient is showing some symptoms, cardioversion can be used in those things too. There is another medication called procainamide, other than amidron, which we can use to reset, or it can be used as dysrhythmic drugs if patient is having an atrium issue. Cardioversion, think about SVT. Think about all the other dysrhythmia. Every dysrhythmia, we can use cardioversion except two. And what are those two? One is VTEC. We know that VTEC is again two types, with pulse and without pulse. So if patient is having VTEC, I'll show you how it looks like, and they do not have pulse, pulseless, but there is electrical activity. VTAC is there, but we cannot find the pulse. Maybe heart is not beating enough, or maybe heart does not do pumping action anymore, but there is electrical activity inside. You don't feel the pulse, means this is deadly one. So we have to defibrillate. And then second one is your VFib, ventricular fibrillation. Those are the scariest rhythm where we use this defibrillation. And other than that, in any other condition, we use cardioversion. Yes, you are right, Meg. So this is again, I think we talk about it, WPAW. Risk, it can cause AFib, tachyarrhythmia, SVT. Management is procainamide or cardioversion. So there's a shortcut pathway. Look at that pathways. They are just originating, because SA nodes should be or supposed to be fired, and AV nodes supposed to be fired. They're bypassing it, and AV node is firing. Plus, ventricles are originating their normal circuit. They should relax at this point, but they are like in the circuit of normal circuit. So adenosine can cut down that abnormal circuit. Okay, so this is another one, PVC. We're not worried about much. Okay, so look at that. What is happening? Premature ventricular contraction. What is happening here? If you see, normally, first of all, ask the same question. Is it normal? So we can see P, Q, R, S, T, and then again P, Q, R, S, T, and then again P, Q, R, S, T, and then there is something drop. So we don't see Q, R, S up, we see down, and then S, T. So P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T, and then there was an extra ventricular contraction. It is extra ventricular contraction. And then again, it is going back to normal, It is going on back to normal. So at that time, we call it isolated PVC. Isolated PVC is not scary. That's okay. If as long as it is coming back to the normal sinus rhythm, that's okay. Isolated. We don't have to worry much. But if you see why it's happening, it's ectopic beat, means extra beat or premature beat before the ventricles contract. So it's not a rhythm, it's just a beat. Okay. So it's an early beat. And instead of QRS, you see that wide QRS bizarre complex. And at that point, we don't see any P wave, right? So pattern could be bigeminy, trigeminy, and quadrigeminy. Now, what does that mean? Every other beat, if every other beat is PVC, we call it bigeminy. Now, look at that. So we have P, Q, R, S, T, right? And then drop. This is PVC. Again, another is normal, and again, we have PVC. So we have one normal, every other rhythm is PVC, we call it bigeminy. So if it is every third beat is abnormal, like PVC, then we call it trigeminy and quadrigeminy and so on. So if patient presents with this, and in addition to that, maybe in the case study, they give you that patient is also having some shortness of breath or chest pain, or patient is not looking okay. So now this is going to be deadly one. Isolated, we are not worried about much, but if it is your bigeminy, trigeminy, quadrigeminy, look for symptoms, right? You see this, plus look at the symptoms. If in the case study, if they give you some sort of symptoms, there is something issue. We need to correct that. How do we correct that? So again, it's PVC, it's lidocaine. We don't need to reset because this is not a rhythm. This is not dysrhythmia. We don't really need to use that shock. And if it is like troubling one, of course, if you see some sort of issues, chest pain or something, maybe we can use cardioversion. But make sure do not give cardioversion when like there is R wave. If you give a shock or add R wave when R wave is forming, it can become R on T phenomena, which is going to be life-threatening. So R on T phenomena, in other words, we can say it is kind of VFib. It can turn into VFib. So every time when I say cardioversion, make sure that you turn on that cardioversion button on defibrillation machine so that we can deliver small amount of electric shock. Okay. So other than that, lidocaine can be the choice of drug. So look at this, isolated PVC is okay. Give oxygen, symptomatic treatment, right? Treat the cause, notify if there is chest pain because it can cause ventricular tachycardia or VFib, right? These are the causes, which are like same causes in every condition: the stimulant, digoxin, heart disease, hypokalemia, hypoxia, or stress. Those can cause PVC. Okay. Okay. So next is your ventricular tachycardia. Ventricular tachycardia, we call it like tombstone. You all must have seen those graveyard, and then on the graveyard on their tombs, there is a tombstone in this form saying that RIP. Right, so these are kind of tombstones, a lot of tombstones. Or in other words, if you see these things, they look like M's, like McDonald's, right? So, or sometimes it's you see top note here, but still it is giving you the same rhythm, like tombstone. So just know this is VTAC, VTAC. Now, what are the main components of it? So now we did SVT. Where we were not able to locate. I think I have this. Look at that. So this is VTAC, right? And if you really see this rhythm, so rhythm is regular, but we cannot really locate P, wave, and we have QRS, and then where is T and where is P? It is blending. So this is SVT. What is the major difference between these two rhythms? So if you see QRS complex here and look at the small box, maybe it's 1 or 1.5 or maybe less than 1, right? But in this, it's no P wave at all. Means atriums, they are not working. It's just ventricles, right? They're like working very fast. QRS, QRS, QRS. We cannot look at P wave. And look at that QR, it's QRS, QRS. So look at that boxes. Could be. It's storm-like, but look at those small boxes. How many of them? 1, 2, 3, 4. Sometimes 4, 5, right? So QRS, if you look those small boxes, could be 4 to 5, 4 to 5. But in SVT, it was 1 or barely 1.5. So in that's a major difference between VTech and SVT. SVT. So VTech, QRS complex is wide. No P wave, QRS is wide, right? But it is regular. QRS is regular. If you really have to calculate this, so you can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 20. Oh my God. 210. So ventricles are like in tachycardia. So think about ventricles are not even relaxing and no blood is there. Cardiac output, think about cardiac output will be very low. So this client can be having life-threatening condition. And that time we really have to check the pulse too, right? If pulse is present, treat in another way. If pulse is not present, right way, do not waste the time. CPR and then defibrillation. Always give CPR when client is pulseless, right? Okay. So SVT, I hope that you got that major difference between VTech and SVT. So here could be, look at that rate, 250. Ventricles are beating very fast, ectopic foci, wide QRS complex, SVT, narrow complex. Here, VTech, wide. No P wave, definitely, and this is regular rhythm. So status could be stable or unstable. If patient is stable, showing no sign and symptoms, but still know that patient can be given cardioversion, right? But if they're unstable, defibrillation without wasting much time. So when they are unstable, what kind of signs and symptoms they can have? Hypotension, altered mental status, unresponsive, heart failure, or maybe shock because heart is not pumping effectively. So shock. So if patient is stable, best drug to give is amiodarone. And if that does not work, then cardioversion. If patient is unstable, then we can always start with least invasive to most invasive stuff, right? VTech. Okay. So we have amiodarone, we have lidocaine, procainamide, sotalol, we can do that. Pulse plus stable. No pulse, CPR defibrillation. I hope that makes sense now. When to give CPR, when to give cardioversion, when to give defibrillation, right? So that depends. Like we do have conditions specifically in tachycardia with pulse and without pulse. Okay, so this is another way of this is sinus tachycardia. Look at that sinus tachycardia. Can we look at P wave? Yes. QRS, yes. And then T wave. And then again P wave, QRS. When you can really locate PQRST, now this is sinus. And moreover, this is like the gap is equal. So this is regular sinus. So that means sinus rhythm is there, PQRST is there. So if you have to calculate that, use that formula. So 300, barely 2.5. You can calculate. We have done so many times, right? And this is looks like ventricular tachycardia. The rate is really high. We cannot locate period. Another very interesting rhythm is torsades, Tapua. So whenever you think about torsades, look at that. These are like whirlpool, that kind of earthquake in the heart. So it's look like whirlpool, earthquake. Some people call it radio frequency lines. Those have like See a special like kind of pattern, kind of curveball and then slow down, and then again big lines and then slow down. Some people can distinguish it like that way, and sometimes it can be given with lots of M's and W's here, M's and W's. That's another way of saying that this client is having torsades. Torsades and V-fib are kind of looks like same. Okay, I'll show you the V-fib, which is the last rhythm. So this is kind of torsades. So here, can we really see P wave? No. Can we really see the QRS complex? Maybe yes, but distorted sometimes. Look at that, distorted. Sometimes it's very long line, sometimes short. So that means it's kind of chaos, right? QRS is there, but chaos. So that is always happening due to two major electrolytes. One is your magnesium, and then another one is your potassium. So when there is hypomagnesemia or hypokalemia, that time you will see torsades. Treat that line. So right away, it should run in your mind that, okay, what kind of labs do we need to see? Oh, do we have the lab? Okay. Magnesium, it's going down. Potassium is down. So maybe we have to give them those things which they don't have right now. Maybe we need to give them magnesium sulfate. We can treat that. If client is having hypokalemia, maybe we need to give some potassium, maybe IV because this is life-threatening condition. Or later on, maybe IVs, like oral supplements can be given to of potassium. Just know that if you give potassium in oral, even though if it is a tablet, it is going to be a big tablet. When you give the patient, it can really irritate that GI lining. Same way, like when you give potassium IV, it irritates the peripheral veins and it can damage those peripheral veins. So best thing, like always, we dilute it and we give via infusion pump. And if central line is there, we prefer that instead of peripheral. But if you give something like tablet of potassium orally, it can irritate that GI. So that's why we always tell the client or teach the client always dilute it because the taste is not going to be okay. Dilute it, or if it is just a tablet, so take it with one full glass of water. And if it is like liquid form comes like you see like how your pizza dippings are. So you open that liquid part and then the patient can take it, but they cannot take it like that because it can irritate, can damage that lining, esophageal lining. So how we can give that liquid part? Pour it in the glass, maybe in the juice, maybe like dilute it and then give it. Trust me, the taste is not okay. So client will complain a lot about the taste when you give potassium things. Okay. So dilution is very important. Otherwise, you can actually damage the patient GI system. Okay. Question on this. So whenever we see any kind of VTAC, what is the first thing that we do? VTAC, check the pulse and treat accordingly. Okay. When you see torsades, check the electrolytes. Okay, maybe pulse is going to be present. It's just only VTAC where we don't have pulse and we have to think accordingly. If pulse is there, this is the treatment. If pulse is not there, CPR, defibrillation. Torsades, we know that's just the electrolyte issue. Give them electrolytes and then maybe we can fix it right away. So this is the scariest rhythm out of all those, whatever we have done. This is going to be the scariest one. There's no pattern. Even though if you see torsades, there was kind of a little pattern we can see. Even though in VTAC, we see tombstone pattern and it is regular. But here, we don't see any pattern at all. No pattern. Can we look at P wave? No. Can we see QRS like nice way? Sometimes it's short, sometimes no. Look at this rhythm. It's just like someone is drawing a line. A kid is drawing a line. We cannot see anything. So that's why this is going to be the scariest rhythm. We have to worry about this because after this, patient can die. Patient can die. Okay, so we have to think like V fibrillation is the scariest rhythm. So what are those two rhythms? First one was VTAC with no pulse, we give defibrillation. Second is your VFib. Right way, without wasting any time, we have to start CPR because ventricles are just like this. Our body is not getting enough blood. So we have to start CPR immediately and we have to shock the client. right? So that's all we can do for our client, because we don't want to see asystole, because there is very like less time this client might be having. It can turn into asystole. Even though if it is asystole, CPR and defibrillation. So these are important points. If a patient do have rhythm, if they have rhythm, do we give CPR? No. How about if they are pulseless? Do we give CPR? Pulseless, yes. Every time, if no pulse, if patient is unresponsive, CPR and defibrillation. If a client is pulseless and have flat line, of course, CPR and defibrillation. Okay. So you should know when to pick CPR, when to pick defib, and when to pick cardioversion. By this time, I hope that you all are pro now. Should be easy for you, right? Okay. We're almost done. So this is called something called ECG artifact. Artifact is always maybe you are not putting those electrodes in a nice way. Maybe they are very loose. Maybe patient is very hairy and those electrodes are very superficial and they're not detecting any heart rhythm, electrical rhythm. Or maybe you're putting those electrodes on over the clothes. There could be a lot of stuff. Maybe patient is shivering and those electrodes are not able to detect what is going on in the heart actually. Maybe they are having tremors or shivering, or maybe they have seizures, something like that. So that time we have artifact. So in artifact, do not get panic. There could be ECG electrode placement issue. Could be like your default, maybe you haven't put it in a nice way or in a nice location. If patient is having loss of hair, maybe you have to clip those here. Clip. Do not use the razor. Clip, okay? Use those special creams to remove those hair. So we can think like they are okay. They are not like scariest for them. Do not think like it's kind of drawing. But look at that. Do not overthink that, okay, before it was okay, but right now it is going like chaos. We haven't done anything like that, right? When you see this kind of pattern, why we have added lots of strips here so that you can have a nice idea. Okay, all right. So that's our ECG artifact. You know the reason. Fix the cause, you'll see the nice rhythm. And of course, sometimes you see this kind of rhythm and on exam, maybe in the case study, they have written that, oh, client is talking, maybe walking around, or maybe he's alert, oriented times 4. So that time we know that it's our fault. Maybe we haven't put it in a nice way. Okay. So this is called sinus block. So sinus block. So how you will know that this is sinus block? So we said that SA node is the one that is firing all the time. So everything is supposed to go okay by SA node. So you can see the PQRST, PQRST. So if you look at this, can you see everything normal? So we can see PQRST, EQRST, and then we don't have PQRST. PV is missing, even though QRS at that point is missing too. Should supposed to be here, it is missing. Again, we see there, we see there, we see there, but here we don't have anything. So that is called sinus block. And sinus block is sometimes when patient is very, very sick, or maybe it's the issue in the SA node. Okay, so we call it a sick sinus syndrome. Like people who sometimes miss a beat. So we call it skip a beat, miss a beat. So means cardiac output. Think about when they're missing the beat, what can happen with the cardiac output? Cardiac output become low. So without any reason, it is like that. So if heart misses the beat, they are producing decrease, or maybe they are having decreased cardiac output. So this is just as it is. We cannot do much. It is not like too much life-threatening if it is there. So maybe doctors can really check that, or maybe can give some dysrhythmic drugs. But it's not like life-threatening like your V-fibrillation or VTAC pulseless. So this is called pulseless electrical activity. You see some pulse is there, and then you see flat line, right? Normal ECG, normal PQRST, regular, and then you see some pulses there, and then a lot of time like you see flat, then QRS and flat. You don't even see P wave. Maybe you see PVC or something like that. So it is called pulseless electrical activity. What is that? Means that on ECG, on the ECG machine or monitor, you will see some kind of ECG going on, but the patient does not have any pulse at all when you check them. It can be in any, like on ECG monitor. So we cannot say that this is normal sinus rhythm. It is pulseless because we cannot, heart is having, how do we put this in this way? That heart is having that electrical conduction inside, but heart is not actually pumping. That's why we are not seeing any pulse. So that's why we call it pulseless electrical activity. Electrical activity is there, but pulse is not there. So what do we do in those situations? ECG is there, no pulse. If it is pulseless, what do we do? CPR. And follow whatever your ACLS and BALS guideline is, how to give the CPR, follow those guidelines. Okay. So when do we see pulseless electrical activity? Anytime when your heart is getting triggered by less oxygen, hypo or hyperkalemia, by hypoglycemia sometimes, hypothermia, hypovolemia, or maybe body is having lots of infection inside, body is in sepsis condition, thrombosis is there, pneumothorax is there. So maybe those are kind of causes which can cause this. But just know that if you see this and if your question is saying that what do you want to do, what will be your initial action? So it's pulseless, right? CPR. Okay, so we are done with that. So now last part is just the quick activity time. Let's see how much do you know. I'm going to show you the rhythm. You have to tell me which one is it and what will be the initial action. Okay? Okay, so it's activity time. So what do you think about this rhythm? What is happening here? Be fast. Let me see. CPR. Do we do? No, that's previous step. What is happening here? Now you guys can unmute yourself and we can talk too. Okay, we're done. So what we can do here?
That's a QT prolongation.
QT prolongation. Do you see PQRST? So we have
In the last strip, I see the PQRST.
PQRST. How about here? So PQRST, and then
Yeah.
PQRST, and then PQRST. So the gap is kind of okay. So first question asks, follow those questions. Is it regular, irregular? First question.
It's a regular.
So now regular. Do we see PQRST? Yes. So now
Yes.
what is it?
It's a sinus.
Bradycardia.
Sinus pulse.
Right, bradycardia, right? Sinus bradycardia. And what will be the initial action? Assess the patient. See whether patient is symptomatic or asymptomatic. Sinus bradycardia, right? So if patient is asymptomatic, it's okay. If they are symptomatic, what do we do? Symptomatic bradycardia. Then we treat. How do we treat? Those three drugs, atropine, dopa, epi. Remember, how do we give atropine? What are those contraindications? Pay attention. Maybe you need to learn, like maybe you need to revise it. Let's see if you know the next one. What about this one? First question. Is it regular? Check that
Yes.
gap. Yes. How about that P wave? Can we locate it? No. Instead
No.
of P wave, what do we have? Sawtooth. So this is
Sawtooth.
atrial flutter, right? Still with me? Atrial flutter. Okay, how about this?
Torsade.
Torsades Zapua. Perfect. So we see those torsades, we see lots of M's, lots of W's. So that's torsades. How about this?
Regular.
Regular.
Regular or
It's
irregular?
irregular.
You see white sometimes.
No.
Here we have white.
Irregular.
This is
Irregular.
irregular. So how about P wave? Can we look at P wave?
No.
So instead P wave, we have waves. So what do we call it? Remember the first atrial problem?
1, 2, 3,
Atrial
4,
Atrial
5, 6,
fibrillation.
7,
E
8,
wave.
9, 10,
Perfect.
11, 12, 13.
So that's a heart rate,
AFib.
but this is fibrillation. Atrium's quivering, AFib. So how about this rhythm? Chaos.
Ventricular fibrillation.
Perfect. So it's VFib. Okay. How about this one? Tombstones,
VTAC.
VTAC. Perfect. And what do we do? What is the first section in VTAC? Assess the pulse. Accordingly, do the interventions. If pulse is there, treatment is different. Pulse less, treatment is different. How about this? Do we see, like, what is the question first? Gap?
Regular.
It's regular. Do we see
Irregular.
PQRST? No. Look at the gap. It's same.
Yeah.
So can we see PQRST and then PQRST, PQRST? Right? We can
Yes.
see that.
Yes.
But now this is sinus rhythm, but before we call it normal, is it brady, tachy, or normal?
It's
Do your math
trachy.
formula. 300 divided by
I think it's trachy.
sinus
1,
tachycardia, right?
5, 6, 8,
Tachycardia.
10, 11, 12, 13. Yeah, trachycardia.
So, but when you have regular rhythm, we use that formula. 300 divided by R2R. That big boxes count, those big boxes. But if it is irregular, then just
Then
simply
it's
say R waves, how many times we have R waves, and simply multiply it with the number of.
by 10.
Okay. How about this? We just did PQRST, 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 and then no.
It's block.
Sinus
Sinus
block.
block.
Perfect. Sinus block, everyone? I can see chat too. How about everyone? Everyone should talk. I'm standing here from last like 2.5 hours. No, almost it's 3 hours.
3 hours.
I'm
That's a
standing. Look at me. I'm standing all the time. So sinus
block.
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 Perfect. Thank you. Next. Again, this is rhythm looks normal.
Sawtooth.
Can we look at P?
Atrial fibrillation.
That
Flutter or fibrillation?
Fibrillation.
So
Flutter.
your fibrillation was irregular. This is regular, and P wave instead of P wave, it's sawtooth. Always know flutter, sawtooth pattern.
Flutter.
Flutter is always regular, whereas A fibrillation irregular, P wave, quivering.
Yes,
Okay.
atrium flutter.
So this is again UV feb. We just did that. Remember? How about this?
ECG.
This is artification.
Artifact.
Artifact.
The artifact.
Yeah.
What will be the initial action in this? Check those.
Check the electrodes.
Check the legs.
Perfect. Sometimes patient can have tremors too, or seizures too, or maybe they are not staying still. So that's why. Okay. So what about this?
This is sawtooth.
Sawtooth. Perfect.
Atrial fibrillation.
Atrial flutter.
Fibrillation or flutter?
Flutter.
Flutter. Sawtooth.
Yeah.
Flutter.
And now this one
It's
is.
the atrial fibrillation.
This is atrial fibrillation. Thank you.
Atrial
Look at the
fibrillation.
gap. This is irregular, and instead of P wave, we cannot locate it. So fibrillation. How about this? So we see PQRST, 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 and then drop.
Okay.
We have
PVC?
in the class too. Okay. So that is PVC, right?
Yep.
Yeah.
So sometimes it is going back to normal. So going back to normal, and then look at that. If it is every fourth beat, quadri, PVC. Bigemini, quadrigemini. How about this?
Sinus.
This is
Sinus
sinus brady.
sinus bradycardia, and symptomatic, then treat it. Asymptomatic, sometimes it's going to be baseline. How about this?
This is
Ventricular tachycardia.
Ventricular tachycardia, remember tombstones,
No.
VFib.
VFib, chaos, right? Can we look at P? No. And even though QRS,
VFib.
torsids were something like radio waves, right? They have some sort of pattern, but it does not have any pattern. So this is VFib.
VFib.
So this is tombstones.
Flutter.
Ventricular.
VTAC.
VTAC. Tombstones, VTAC. This is,
Normal.
look at the gap, gap,
Normal.
normal, but is it normal,
Normal.
Brady,
Uh.
techie, what?
2, 3, 4, 5, 6.
2, 3, 4, 5, 7, 8.
So no, if it is normal, use this formula.
150. Tachy. 3 by 3.
304.
Yeah.
300.
Sinus. Regular.
Normal sinus rhythm or what? So if it is like, let's say if it is like,
Normal.
look
75.
online, this is 1, 2, 3, and 4. Sometimes it's 4, sometimes 4.5. So
Normal.
it's normal sinus rhythm, right?
75.
Thank you. So how many
75
boxes are
BPM.
you picking? 4 or maybe 4.5? Even though if it is 4, 4 sevens, 28, 2, 0, 4, 5, 6, 20, 75,
It's normal.
right? And last one, before I say you guys, thank
It's
you. It's last one. Tombstones. Even though if it is naughty, top notch is there.
Tachycardia.
VTAC.
Tachycardia.
ventricular
Tachycardia.
tachycardia.
So that's it, guys. I hope you enjoyed this session. This was free of cost, and maybe in future we will do more sessions like this. Okay, and make sure that you are like studying, and if you're planning to write your NCLEX-RN exam, don't miss this lecture. This is going to be lifesaver, right? So you have learned a lot, and pat yourself that you did a lot. You did very well. Thank you again. Thank you so much. And make sure that just give us like comments or maybe just leave a Google review, however you like it. If you like it, then give some review. If you don't, that's okay too. Okay.
And
All right.
you're going to post it on YouTube or not?
Of course, I will do that.
Thank you.
Thank you so much, guys. Thank you
Thank
so
you,
much for
ma'am.
joining. Bye-bye.
Thank you.
Stops.